Good evening, everyone. I'm Dr. Surajit, and welcome everyone to the Masterclass on Vertigo. Before starting, I would like to pay my homage to our friend, Dr. Hitesh Shah, who passed away unfortunately yesterday evening. He was a true gentleman and a true friend, and I hope that the Almighty gives strength to his family and his near and dear ones. I now hand over the mic to Dr. Swapnil to deliver the opening welcome address.
Yeah, Dr. Sujit, thank you very much for the warm welcome. I'm Dr. Swapnil, Medical Advisor with Abbott. On behalf of Abbott, I would like to welcome you all to this 3-day event of Vertigo Masterclass, wherein we have stalwarts speaking on various interesting topics of Vertigo. And I'm sure there'll be a lot of interesting insights that we all take home from this useful initiative. Before going any ahead, kindly allow me to quickly share
Good evening, everyone.
to quick,
This is Vijay, and welcome everyone to the.
yeah, so kindly allow me to share uh, a few initiatives that Abbott is trying to take in the field of neurology and vertigo, to be specific. So I will quickly throw light upon these. So Abbott has been nurturing healthcare since the last 130 years, and it's truly a global company with a footprint in 150 countries. In India, we have three manufacturing plants where the local R&D works for localized solutions with more than 100 researchers. Throughout these 130 years, we have breakthrough health products in the field of pharmaceuticals, diabetes care, nutrition, cardiovascular diagnostics, and neuromodulation, uh, delivering the highest quality of trusted medicines to help people get and stay healthy in the field of branded generic pharmaceuticals is what is our motto. And we have the therapy areas of gastroenterology, cardiovascular health, women's health, respiratory medicine, central nervous system or pain, and influenza vaccines, where we work in the branded generic pharmaceuticals. We have several innovations which we have already got under our belt, and there are various awards and recognitions that Abbott has been awarded with for all of these initiatives that we took. Some of these important initiatives are like the in-clinic scientific detailing in virtual reality, which helps in finding the right diagnosis, also gives clues about the pathology of vertigo and so on. We have the vertigo guidelines, which we have released with the help of Dr. Mohan Kameshwaran, also being actively involved in it, and that has been published with the Theme publications. The guidelines have been published last year. Uh, there is a Vertigo app that we have, wherein there are the vestibular rehabilitation exercises, which are very much there online and can be accessed. Also, there are some dietary recommendations that are given by experts, and they can also be accessed in the vernacular mediums, which is an important addition to this Vertigo app. I would request all the respected doctors here to kindly share about this particular app with their patients for their own benefits. Apart from that, there are these robotic heads which help us master the maneuvers and see what are the changes happening in the nystagmus. These robotic heads are something that all of you might be familiar with and have already seen in your own clinics as well as in most of the conferences. Apart from that, there are the diagnostic tools, the indigenous tools which have been developed by Abbott. There is the bucket test and the M glasses, which help in the right diagnosis of the type of vertigo, and and these are all available. If at all you still have not got them, kindly do contact our Abbott colleagues, and they'll be more than happy to help you out in getting these diagnostic tools for your own practice. Apart from that, there is an initiative that is called Knowledge Genie. This is an app-based initiative wherein we share the latest publications on the particular app, and you can easily download that from the Knowledge Genie app. If you want more information, you can still contact some of our Abbott colleagues, and they'll help you out in getting an access and going ahead with this particular app. We have been partnering with Indian Express to digitally enhance the understanding amongst about balance disorders. So in this space, we have released so far 1,000 plus specialists who have given a lot of videos. These are small snippets wherein important points about diagnosis, about balance disorders are shared by the biggest names in Vertigo. Uh, these videos were shared from around more than 160 headquarters of Abbott, so across the India, and we have also got more than 3 lakh views as and when this portal was launched till date. So there is a tremendous response, and I thank you all for this overwhelming response and sharing these videos, sharing these insights with us. And I also encourage for those who have not yet shared their videos with us, kindly watch out this space, and we would love to get your videos also there. As I had explained, Knowledge Genie, the portal wherein more than 2,200 journals are instantly available as PDFs. There are some over more than 400 presentations and about over 140 clinical guidelines to take informed patient healthcare decisions. It gives an access to ebooks, like more than 2,500 ebooks and a lot of CMEs, uh, over 270 simulation cases that are accredited by the European CME CPD Academy. So to that, just to add an interest of element for the young doctors that we have, there is India's first medical game that is designed for all the young doctors called Knowledge Genie. On this portal, there are interactive MCQ-based quizzes to prepare the young doctors for all the competitive exams and to prepare them for the real-world scenario. It gives an access to top journals, ebooks, CME, and resources. In addition to that, there are 11 key specialties that we've covered, like internal medicine, psychiatry, ENT, and neuro, and the monthly winners do receive medical books as prizes. So with that, I would like to hand over now the proceedings to the organizer. Over to you, Dr. Suji.
Thank you, Sapnil. Without much ado, I'll now straight away request Dr. Gautam Khan, the convener of our session today, to give up the context of this meeting. Over to you, Dr. Khan.
Thank you, Surajit. At the outset, I'd like to welcome all the speakers from various parts of India, all the viewers who are on YouTube as well as on the live med for joining us today. We hope that this webinar series on vertigo will be very useful for you. We have tried to mix and match the wisdom of some of the senior-most people of India who are dealing with vertigo, Dr. Anirban Biswas sir, Dr. M.B. Kirtane sir, and Dr. Mohan Kameshwaran, along with the chief mentor, chief resource faculty, Dr. Srinivas Dorasala, who is well known in the vertigo circles, and a host of speakers from various corners of India who have been devoting their energy in the furthering of the knowledge of vertigo. A couple of years back, once I read a textbook on vertigo, and in the foreword, the gentleman starts off with the line that why another book on vertigo? Well, some of you must be thinking that why another web series or webinar on vertigo? There have been so many over the last few months. Well, there's always something more to learn. There's always something more to understand. And we hope we have tried to structure it. I think if we want to make it a very thorough, it will need more than a week of series. In this series, in the first day today, it will be mostly on the basics about anatomy, physiology, history taking. Tomorrow it will be about peripheral vertigo. And the day after will be rehabilitation and non-peripheral causes of vertigo. So with these words, I welcome you again, and I hope you will enjoy the proceedings of the next 3 days. I thank Swapnil on behalf of for representing Abbott NeuroLife, who have been our partners in this, and we are also collaborating with the Indian Academy of Otolaryngology and Head and Neck Surgery. I thank Dr. Vijay Krishnan, Secretary, and Dr. Handa, the President, for agreeing to collaborate with us. Now I'd like to introduce to you Professor Dr. Anirban Biswas sir, the keynote speaker for today. Dr. Biswas sir actually it's a glitched word, doesn't really need any introduction in India. He has been one of those who has sort of revolutionized, or his effort has actually sort of popularized the subject of autoneurology in all over India and Indian subcontinent. In my knowledge, he is the first person to have taken up autoneurology to become a true full-fledged autoneurologist. Our relationship with Dr. Anirban Biswas goes back a long way. I was just asking him before we started. He did the first ENG workshop way back in '96 in the medical college when Dr. A.C. Sharma sir had organized it. Later on in Nightingale Hospital also, he had done a ENG workshop in around 2008 with Surajit, who had just joined in at that time. And over the years, Dr. Anirban Biswas has been instrumental in organizing so many workshops and meetings all over the country and abroad. He has been the past president of the AOI, the past president of the NES, the past president of the Indian Academy of Otolaryngology and Head and Neck Surgery. He was also the editor for 5 years of the Indian Journal of our Indian Journal of Otolaryngology and Head and Neck Surgery. He is a member of the Berenice Society, an exclusive society again, and he was the ex-vice president of the International Neurological and Equilibriometric Society. He's a recipient of the Tato Clausen Award and a recipient of the Frenzel Sakata Award for contribution in the discipline of neurology. His 2 textbooks of clinical audiovestibulometry and an introduction to neurotology, amongst many other books that he had written, these 2 specially have been university approved textbooks in neurology. Actually, if I keep on talking about Dr. Anirban Biswas sir's achievement, it can go a long way. I think I'll end here about his introduction. He has been instrumental. We are thankful to Dr. Anirban Biswas sir because he's been instrumental in spreading the knowledge of otolaryngology in the Northeast, and he has always encouraged the talents in the Northeast for learning. Most of them have been to his workshops, including Surajit, Anjana, who is also here. Thank you, sir, for accepting to be here as a keynote speaker for day 1. And with these words, I request Dr. Anirban Biswas to start his deliberation. And from now on, Srinivas Dorasada, the chief faculty, will take over. Thank you.
So I request Biswas sir to kindly inaugurate this masterclass on vertigo and deliver his keynote lecture. I now hand over the mic to Dr. Srinivas. So Srinivas, all yours, sir.
Thank you, Dr. Surajit and Dr. Gautam Khan for giving this beautiful opportunity for me to be with you again. It's always, though not physically, now virtually, we are coming to the Northeast, and it's always a pleasure to Putra and be with some of the finest people I've come across. Okay, so I don't know, for some reason, Dr. Surajit's video is frozen, or he has become a statue. I don't know. Okay, so now may I have the honor of inviting Dr. Anirban Biswas to inaugurate the session.
Acha. Do I share the screen or do I not share the screen now?
You can share, sir. You can share.
Yes, okay. We can see us.
I start with sharing this screen right away. Okay.
Yes, sir.
So I think the best way of starting this is to go directly into the lecture rather than anything else. Already a start has been given to this, and
Yes,
there's
sir.
nothing more to give it a start. Only 2-3 things which I would like to say before beginning is that in India, the scene in neurotology is very fast evolving, very fast changing. And one thing that all of us have to know is that what we are doing in India is nothing lesser than whatever else is being done in other parts of the world. Now, until we realize this and we know this, we will not be able to take the science forward. Excellent work is being done in neurology in India, and with the efforts of Dr. Srinivas and some other doctors also, the thing has now become popularized in a big way. And in small towns also, you'll find proper neurology setups and all these things are there now. And it has been possible because of this Make in India things that has started. And a lot of things, lot of interest, lot of changes are taking place. Two new things that have happened in the last few days, I would say, is that one is this new Indian instrument on VNG by Dr. Srinivas's organization that has got the CE marking, which is a very big thing. I do not know how much you are aware of these things, but those of us who are in this circle of medical instrumentation and all, it is a very, very big thing. And Dr. Srinivas and his efforts and his team needs a big applause for bringing an Indian thing to world standards. So that is something extremely great. So I think we need to recognize that one. This is a big event for us. And secondly, there are now a lot of books, publications, and all that are coming in neurology. Possibly next week there will be an e-book released on BPPV by Dr. Anita Bhandari. They're all of them, all of you are doing excellent work. When I had started practicing in neurology way back in 1986, there was nothing other than a ENG machine where we had an ink pen where the graphs used to come on a piece of paper, and with a protractor and with a scale. I used to sit at night measuring all the different angles, calculating with a we did not understand so much about that, why we are doing that saccadic test, why we were doing those pendulum tracking tests. We used to know that these were a part of ENG, but our main focus was on caloric test. But as the science has evolved, everything has started changing, and now we are on a completely different platform. All those mechanical things and those things which kept doctors away, sitting away late at night, and then measuring those things, drawing with a scale and paper. You see, it's a long way back. Many of you may not have been born even then. It was 86, 87, 88. My first my ENG machine was from 1985. So it's a long way. So many years back, and I've been in this line, and we have seen the science grow. And now we are in a much higher platform, much higher platform. And so that has happened because you people have taken it up. I think for the first 20 years or so, after taking the mantle from Kirtane sir and Dr. S.K. Kakkar, Professor Y.N. Mehra, with whom I have trained basically I have taken the mantle from them and kept the thing burning for about 20 years. And then a lot of new people came in, like Srinivas and all, like Srinivas, Anita, then Dr. Jagtap, Dr. Surajit, Dr. Avinash Bijlani, many people started coming in. But then for about 20 years, I think I was there alone. But now a lot of new people have come and then doing excellent job. And the biggest joy of this entire thing is seeing and experiencing that people who have learned from you, people who have come to you, who have learned from you, who have worked with you, they are overtaking you, and then they are becoming bigger names and doing excellent work. And you see, today I have no qualms in saying that if I have a problem in anything, many a time I do call up many of my juniors, like I would not want to take names, but many of my juniors I do call up because I know who is good in which particular thing. So I call them up whenever I see a patient in front of the patient. I have no problems in that. In front of the patient, I call them up, ask them, let's say, ऐसा होता है, क्या होना चाहिए? What do you think it is? So that gives us a very, very big pleasure. And yesterday when I heard about Anita's book, which will be released, I think on the 6th of September, I felt so very happy that we are taking the science forward. Okay, so now with this, I believe we are in a position where we can start the lecture today, and and this is enough to start the as Dr. Gautam Khand and Dr. Surajit had told me that to inaugurate this thing, I think this has been more than an inaugural lecture. And so off to the subject. Now my topic as given today is vestibulometry, pros and cons and relevance in clinical practice. So this is my topic today. And I find that today I have again one of my juniors who has worked with me, Dr. Pratik Porwal. He will be talking on the vestibulometry subject and what is new. So I believe Pratik will be talking on the pros of vestibulometry. So I will limit myself more to the cons of vestibulometry, such that Pratik does not overrule much of what I have said, and I do not overrule much of what he has said, because the signal has to be the same from the same platform. Okay, starting with now vestibulometry. What is it? See, over the last 10-15 years, very rapid developments have taken place in neurotology, and today neurotology is a completely evidence-based science where we can document any abnormality in the vestibular system with utmost precision. This has come in the last 15 years or so. And this is true. And this is what we have been propagating and preaching. And there is no denying that this is partly, if not wholly, true. But the result of this is that our focus on diagnosis is changing. The different diagnostic tests and the investigations are advertised so very much by the manufacturers of the diagnostic equipment and by the local clinics of vestibulometry that have come up and mushroomed each and every corner of this city. They advertise these tests so very much that people now have an idea that if you don't have the test, you cannot run a vertigo clinic, or that it is the tests only that is necessary, and without the test you are nowhere. What I would intend to say is that yes, the tests are definitely necessary. During my talk, nowhere should the signals go that I am saying that the tests are not necessary. Tests are 100% necessary, and there is a huge relevance of the tests. That is there. There is no denying of that. But at the same time, I would say that the tests in neurotology are not, these investigations in neurotology are not like investigations of a blood test or a MRI or something where you are where you are getting a very definite result. Here, the tests have to be analyzed. The findings of the tests have to be analyzed in relation to the history and the clinical findings. The tests themselves do not carry much meaning. So this is what a astute clinician has to understand when he is doing these investigations. So let us start from here and then we take it forwards. Now, what is that we test, and what info does contemporary vestibulometry give us? Now, today we are in a position where each individual part of the vestibular labyrinth can be tested, and for some parts, the functionality can be evaluated even at different frequencies of vestibular stimulation, like the lateral semicircular canal. We can stimulate it at different frequencies. Even the superior and the posterior semicircular canals, we can stimulate it at certain high frequencies. So frequency specific stimulation of at least some parts of the vestibular system, of the vestibular labyrinth, is also now possible. For each part of the vestibular labyrinth, there is a specific function. Each part is a different sensor. the vestibular labyrinth is a sensor of balance. Now, there are different parts of it. There are 5 basic parts of it, the 3 semicircular canal and the 2 otolith organs. Now, each of them test one specific function. And we today have tests by which we can find out which specific part of the balance system is malfunctioning. We can today know whether it is the superior vestibular nerve that is defective or the inferior vestibular nerve that is defective, whether it is the main trunk of the vestibular nerve that is defective, and so there is so much of information that we can get. And today the diagnosis can be pinpointed, and very precise topographical diagnosis is possible today. So remember this, that this is where we are, and as I've shown over here, for each and every part of the balance system, we have got very specific tests. Now, the diagnostic tool available today are for the vestibular function test. We have ENG, VNG, ocular vamp, cervical vamp, subjective visual vertical, video head impulse test, dynamic visual acuity, posturography, some craniocorpography. Then there are some allied tests, all related to vestibulometry, like the photonotometry with localizing tests, BERA, ECOG, nerve conduction studies, somatosensory evoked potentials, imaging studies, and transcranial Doppler. So most of these clinics have, at least most of it, some very sophisticated clinics like ours will have everything. So that is how this system starts. The point is that, yes, we have everything, but how much do we use them? How much is it necessary for diagnosis? And is it true that without all these machines, you will not be able to diagnose a patient of vertigo? No, that is not so. And if you have these machines, would your history taking and would you be able to override the history taking and the clinical findings? No, not at all. So that is what it will be the essence of my communication to you today. Now, for each anatomical part, see, this part will be taken in greater detail by Dr. Pratik Porwal, I understand from the list that has been sent to me. So I'll not go into them, but just to touch upon it. Like the lateral semicircular canal can be evaluated by ENG or VNG at low frequencies, and by the VHIT at high frequencies, the anterior semicircular canal and the posterior semicircular canal at different high frequencies. By the VHIT, we cannot test them at low frequencies. The utricle can be tested by OVAMP and by subjective visual vertical. The sacule can be tested by CVAMP. The superior vestibular nerve by a combination of ENG or VNG and the OVAMP. The inferior vestibular nerve by CVAMP, and it has not been put over here, and also the posterior semicircular canal VHIT. By combining the cervical vamp and the VHIT of the posterior canal, we can evaluate the inferior vestibular nerve also. Then the oculomotor system can be excellently tested and documented by our VNG tests. The sense of the gravitational vertical we can test by the, it's not the sense of gravitational vertical, it is the sense of subjective visual vertical that we can test by the subjective visual vertical test. So this is a little correction that I need to do in this slide. If we don't test the sense of gravitational vertical, we test the sense, our subjective sense of verticality. That is what we test by the subjective visual vertical. So there is an error in this slide. And then the neural pathways that connect all the different parts of the balance system, that we test by NCV, SSCP, and the other tests also. So for each part, you have different tests. But whatever be the test, there is nothing to beat a thorough history taking, a proper clinical examination, and the clinician's clinical judgment. All vestibulometric tests are only as good as the man behind the machine and the clinician interpreting the test. There is a practice now of this third-party test or remote test. Somebody has a clinic, send the vestibulometric patient to somebody else, where a non-medical person, not even a doctor, he does the test. Then a third party, not even that party, some other party analyzes that result, sends a report to the doctor. See, it does not work that way. So a lot depends upon the clinician who is seeing the patient and interpreting the test. You just cannot pass it on like that. There is no remote testing that is possible for vestibulometric test. It is practiced, and you'll find a lot of people who would be after my blood for saying so. But the point is, what I am saying, what I believe, that all vestibulometric tests are only as good as the man behind the machine and the clinician interpreting the test. So that is extremely important, and we want that all clinicians who are practicing in Vertigo and who have these instruments, they themselves learn the process of doing the tests, interpreting these tests, and understanding the nuances of these tests. Then third is, just a test report without the detailed relevant history and a thoroughly done clinical test means nothing. Test battery approach is essential. Vestibular system cannot be assessed by a single test. So these are the four basic things that I wanted to convey before going into this thing. It is extremely important who does the test, what instruments are used for doing the test, whether it is a properly certified, authenticated machine or not, whether it is a properly calibrated machine or not, the man behind the test, that means the technician who has done the test or the clinician who has done the test, whether everything has been maintained well while doing the test or not. See, just small things like you're doing a caloric test. Now, if you as the clinician are doing it, you understand the difference between giving a time gap of at least 4 or 5 minutes in between a warm stimulation and a cold stimulation, or in between two successive stimulations. If you are giving it to a third party, that third party will possibly not even give 1 minute gap, and he will do all these things together. So entire thing will become wrong. Then if in doing a VNG test, it is extremely important where the patient is sitting and where the screen is. The distance between them has to be perfect. If that is not there, then all the things will come improperly. So it is extremely important that somebody who understands, somebody who is committed and dedicated and who is a perfectionist does the tests themselves. And the interpretation also depends, it's a clinical interpretation. The tests themselves do not mean anything. I'll come to that later on. But this is just in this half an hour time, I believe I've already taken 6-7 minutes already gone. Anyway, but then this is what I'm keeping a tab on the time. I believe I have to finish by 10 minutes, 15 minutes past 6 or 10 minutes past 6, something like that. Anyway, so what do we do? What do we test? We test the structural integrity of the balance system, the 5 parts of the vestibular labyrinth, the oculomotor system, and the different neural pathways. We test the functional integrity of the balance system. We test the functional integrity of the balance system, and basically the function of gaze stabilization, of postural stabilization, and of the perception of verticality. So that is what we test in these different patients. So this is what we test. The point is not what we test. The point is, what do we not test? Because that is not the only part of the balance system. What do we not test? We do not test the cognitive system, especially memory. We do not test the psychic system. We do not test the central nervous system comprising of the visual and vestibular cortex, which actually control the functioning of the balance system, and the subcortical centers that perceive the sensation of balance or of imbalance and vertigo. See, this part you have to pay a little attention to, because all the other parts you're testing, but you have to know what you're not testing. Because when you are at war with somebody, you will have to know what are your weaknesses rather than what are your strengths. So the strengths we know, but we also have to know about what are our weaknesses. See, there's a huge part played by the psychic and the cognitive systems in the maintenance of balance, and the way the individual, that is the patient, perceives balance. The inputs to the balance system from the visual, proprioceptive, and labyrinthine senses for all of us. But different persons like Srinivas, Surajit, Gautam, myself, Nilotpal, Anjana, all of us are different persons, and we will utilize this input from the three input systems, the visual, proprioceptive, and the labyrinthine systems, the three of us will utilize these inputs and assimilate it differently. And how much we can read the information from the senses, how much we are storing in the brain, when the time comes, how much we are retrieving, all this will be different for all of us. And this depends on the cognitive skills of the patient, not whether the receptors are perfectly working. The vestibular function tests only evaluate the functionality of the receptors and sometimes that of the neural pathways, nothing more. You do not test anything more. It is like this. Let me give a small example. Like, see, there are 10 students in a class. Okay, 10 students in a class, and you have given them 2 pages to read for half an hour. You have tested their eyesight, and everybody's eye is a perfect 20 by 20, perfect visual acuity is there. That means the sense organ for taking in the information is perfect for all of them. Fine. Now, after half an hour, if you give 10 questions to answer to all these 10 students, somebody will be getting 10 upon 10, somebody will be getting 2 upon 10, somebody will be getting 5 upon 10. Why? This will happen because though their input systems were normal, how much the individual has been able to take into the brain, utilize it, store it in the vestibular memory, and retrieve it from the vestibular memory at the time when it is required will be different in different persons, because that depends upon the cognitive skills of the person. Do we test your cognitive system? No, you don't. So if you don't test the cognitive system, you are actually missing out a huge portion. Then you are not testing memory. Memory is a very, very important part. In a book of mine, which is coming out recently, there's a chapter on dementia and the balance system. It has been found that patients of Alzheimer's disease and patients who have dementia, they have very poor balance function because the balance system is linked with our memory. So it is extremely important that we test the memory. In our clinic, see, nowadays we don't afford to keep the psychologist now because of this income has come down to 10-15% of what it was initially. So, but then we have a system in our clinic where we have a psychologist who does the HADS and evaluate the patient psychologically, memory test, cognitive system test, all this is done. These things don't require much of instrumentation. They have questionnaires. You need a person to do these things and you don't have to invest a lot of money, but you are missing out a huge part if you are not testing them. Then there are lots and lots of other things, like how much you are perceiving the balance disorder. That will depend upon the functioning of the limbic system, because these subcortical centers, they are different in different persons. In some person, they will pay money to enjoy vertigo in a amusement park. And some people, while lying down in bed, they get 2 seconds of a sudden head spinning and they'll come running to the doctor. And some people will sit in the sofas and getting scared to lie down at bed in the night because they think that if they lie down, if they get vertigo. So you see, the perception of vertigo is different in different people. So these are all things, and the vestibular system is deeply linked to our limbic system and to the hippocampus. A study by Dr. Thomas Brandt and all done in 2005 had shown that in persons in whom there is a vestibulopathy, bilateral vestibulopathy, in them, the size of the hippocampus reduces on an average of 17 to 18%. So you see, these are all linked. So until we test everything, you will not be able to evaluate your balance system fully. Don't think that just because you have a VNG system or you have a costly VHIT system or this and that, you have been able to enter into the realms, into the brain and evaluate the balance system totally. No, it is not like that. So that is what we want to tell you. Now, some basic questions on vestibulometry. Do the vestibulometric tests give us more information than a properly done clinical test? Think about it. Is the information obtained from vestibulometry reliable and foolproof? Is the test authentically done under medical supervision by a competent person who understands the nuances of the complex vestibular physiology? Do the tests tell us the nature of the pathology? What is your answer to all of these questions? Yes or no? I cannot get a feedback from you. But then, what is the answer? You just put your hand on your heart and give me a true answer. What is the answer to each of these questions? It's possibly no. It does not tell us this. Why? Do the vestibulometric test, let's start from question 1. Do the vestibulometric tests give us information, more information than a properly done clinical test? No, it does not usually. An experienced examiner nystagmus as small as 0.5 degrees per second. All references are given here. All studies carried out. All references are given. Nothing is there which I am saying. Everything has been documented, and all these are from white-skinned people. You may not believe a black-skinned or a brown-skinned person like me. But what I am saying is from white-skinned people. So please accept what I am saying. The references are given over there. Take a picture of it. Go through these things and you will be convinced. You may think that I have got something against these instruments. No, I don't. I have all these instruments and we use all these instruments very regularly. But then the concept, for vertigo clinics, you need this, you need that. Your father has to spend more money than he had spent in your entire medical education to buy you equipment like this. That is all nonsense. That is what I'm wanting to say. ENG can theoretically measure nystagmus with the intensity of about 1 degrees per second. But in practice, however, the intensity, nystagmus intensity than 2 to 3 degrees per second before it can be differentiated from noise or from artifacts. And it is said that this is the reference, Agar has said, that it is unreliable, ENG is unreliable for eye movements of less than 5 degrees per second. Then VNG, of course, is much better. VNG has a resolution of 0.1 degrees per second, but it may detect movements only about 0.5 degrees per second in laboratory conditions. In clinical conditions, it will be a slightly higher, but then that is the same as the nystagmus that you are seeing clinically. And VHIT, however, is much more sensitive than clinical HIT. Now, here I would like to add something. That is, what is the difference between having the VNG or the ENG and you are looking into the eyes? The difference is that in VNG or in ENG, you are being able to, that means you are being able to take vision away, and when you are taking vision away, then the nystagmus becomes much more prominent in peripheral lesions. So if you have a Frenzel's glass by which you can examine the eyes properly in darkness, or with the eyes open but without any light, a Frenzel's glass gives you this opportunity. Not the type of Frenzel's glass that you saw just now in that Abbott advertisement over there, Michael's glasses. They're good, but then they're not as good. If you want a real thing, then get, if you're wanting a real thing, then you have to have a proper video Frenzel's glasses. Like I have seen this, even in our country, these are made now. This what Cyclops makes or what Neuroequilibrium makes, all these VNG machines, they have a function of video Frenzel also. So you can use just that video Frenzel for doing your clinical test if you have them. Or you can just buy a video Frenzel or any high quality Frenzel's glasses where you can see it and record it. So that is necessary. Then the relevance of VFTs, what do the experts say? It is, again, expert does not mean me. Experts means from whom we have learned. So these are all the big people of neurotology, the gods of neurotology who are worshipped day in and day out. So this is from some of their findings. The diagnosis of vestibular disease is not based on the result of the vestibular function tests. This is the reference. Vestibular testing is an addition to the clinical history and physical examination and merely supports the diagnosis and treatment of vestibular disease. These are the references. The patient's disability does not correlate with the degree of the functional loss that is found on these tests, which means if you have done a VNG test and you have found that I have a 64% canal paresis and another patient has got a 28% canal paresis, it does not mean that the person who has got 64% canal paresis will have a bigger functional loss than that patient or more morbidity than that person who has got 28% canal paresis. So the patient's disability does not correlate with the degree of the functional loss that is found on these tests. Then the tests of vestibular function are not specifically designed for diagnosing disease or the etiology. This is the most important thing. What you as a clinician are interested in knowing, how or what is the patient bothered with? Patient is bothered with one thing, that whether you have been able to diagnose the disease and whether you have been able to treat the disease properly or not. That is what you are here for, and that is why you are what your patient accepts from you. But these tests will not tell you what is the disease, that means what is the etiology, and it does not help in treatment. It does not. How is the treatment going to? I mean medical treatment. How is the medical treatment going to help you if you know that your patient has got a 86% hypoactivity of the right saccule? In cervical vamp you have done and you find that the right saccule is 85% hypoactive as compared to the left side. Does that help you in treatment? No, it does not. So you see, these are things which you have to keep these things in mind, and that this is what experts say, not me. Now, you have got a wonderful VNG machine. You have learned this subject very well. You have been to all these places where these things are taught. You have interned there. You have learned it, and you have done the test yourself, and you have got a 57% canal paresis in VNG. Okay. Does it help in diagnosis or in determining treatment? See, 57% canal paresis in VNG, it can be due to so many things. It can be due to vestibular neuritis of the left side. It can be due to cochleovestibular failure or labyrinthitis. It can be due to an acoustic neuroma of the left side. It can be due to Meniere's disease of the left side or a Meniere's disease of the right side also, if it is in the hyperactive irritative stage. If the right side Meniere's disease is in hyperactive irritative stage, then also you can get a hyperactive lesion, comparatively hyperactive lesion on the left side. And it can also be due to multiple sclerosis. So there are so many things. How does this information of 57% canal paresis help you in diagnosing this? I'm repeating the same thing over and over again. Please do not misunderstand me. I am never ever saying that do not do the tests. I am saying that you do the tests if you have the time and the inclination. History, do the clinical tests correlated with the other findings such that you can find out the difference between all these different types of diseases, and that the tests are not going to tell you. This is where your clinical acumen, where your history taking and your clinical tests will come into use. And without that, just a finding, the patient comes with dangling a piece of paper where it is not a piece of paper, a bunch of papers neatly packed in a folder, in a file. He'll take it out from a nice packet, bring it to you, and you find that there's a 57% canal paresis. And so what does that mean to you? Does it mean anything to you? No. So you see, today what we have is, we have all the different international organizations that have come together and they have made practice guidelines. And these practice guidelines are not, again, not like I just now saw something called a Vertigo guidelines. Now, these practice guidelines are not something from any pharmaceutical company or from any instrument company. These practice guidelines come from scientific bodies, not advertised by pharmaceutical companies. These things come from scientific bodies like the Barani Society, like International Headache Society, then the American Academy of Neurology, and different types of organizations, internationally respected organizations. They come out with the guidelines, and in none of these guidelines for diagnosis of diseases, you will find that there is any mention of any of these vestibular function tests. I'll go through them fast one by one. There's lack of time. Vestibular migraine. These are the criteria for diagnosis of vestibular migraine, and these are the different references on which these are made. Is there any place where it has been mentioned that do the vestibular function test and this is the result of the vestibular function test by which you'll be able to diagnose that? No. So no mention of any vestibular function test in any of these guidelines, practice guidelines. So hence, as per practice guidelines, no vestibular function test is required for diagnosis of definite vestibular migraine. Vestibular migraine probable, same thing. No mention of any vestibular function test over here. These are the criteria. That means, as per practice guidelines, no vestibular function test is required for diagnosis of probable vestibular migraine. Meniere's disease, these are the criteria. And these are the different references. Nowhere is it ever mentioned that you need to do these tests for them. Though ECOG and glycerol test does help in diagnosing it, but it's basically the history, the typical history will have to be there. So if you have not spent that half an hour taking the history, all these papers don't mean anything much. So no mention of any vestibular function test in any of these guidelines. Hence, as per practice guidelines, no vestibular function test is required for diagnosis of Meniere's disease. So same thing. Vestibular paroxysmia, again, these are the criteria. No test mentioned, no vestibular function test mentioned over here. No mention of any vestibular function test. Hence, as per practice guidelines, no vestibular function test is required for diagnosis of vestibular paroxysmia. Vestibular bilateral vestibulopathy, this is the only disease where these tests are necessary. So this is the only disease because where the tests are necessary, where you have to have less than 6% per 6 degrees per second on each side together, and the VHIT also will have to be less than 70%. So these are the only bilateral vestibulopathy. There is mention of the vestibular function test in none of the others. Benign paroxysmal positional vertigo, you will know it much better than me that there is no question of doing any of these tests. So these are the criteria for diagnosis of BPPV. So no mention of any vestibular function test. As per practice guidelines, again, no vestibular function test is required for diagnosis of BPPV. So lateral canal, posterior canal, everything, anterior canal. So bottom line is what? Bottom line is that as per standard practice guidelines, none of these vestibular function tests are actually required for diagnosis of any of these tests. Is that clear? Now I have run out of time by quite a bit. I will not go into much further details. Gautam, you can always tell me that can I take 5-7 minutes more? Gautam or I believe either Gautam or Srinivas
is. Sure, sir. Sure, sir.
You don't mind 5-7 minutes more?
Sir, you can take, sir. You can take, sir.
Definitely,
okay,
sir.
Srinivas.
How can we mind that?
Okay, Srinivas. Thank you.
Yes, thank you, sir.
Thank you very much. See, this is what I like. Srinivas, though my saying so, Srinivas and me remain as close as ever. He will never ever take it that I have in any way tried to say that tests are not necessary. Again, I'm saying the same thing. I am never ever saying that the tests are not necessary. The tests are necessary. But then what I'm meaning to say and what I'm trying to drive home is that these tests do not overrule or override your clinical tests and the detailed history taking. This clinical test and detailed history taking is much more important than these clinical tests. And these clinical tests are good only in very safe hands, and there are not many pairs of very safe hands. Let me also tell you that there are not many pairs of safe hands, because we have those Srinivas is doing and also other organizations are doing. I also do workshops on vestibular tests and all. Anyway, since these things are not taught in the undergraduate and postgraduate ENT and neurology curriculum, and people don't require to pass tests and how to do a VNG properly, how to interpret it. Without doing that, they can pass the tests. And if they can pass the tests without learning to do this, then though it's in a very bad shape. Then you will not develop those good, safe pair of hands by which these tests can be properly done. Because wrong tests are extremely, extremely uncommon. And very often, very, very often I find that due to wrong recording, some artifacts have been recorded, and then a lot of meaning has been made out of that artifact, but there's no solid meaning. And out of that meaning, of that wrong meaning that has been made out of that artifact, what did the patient receive? The patient received an anti-epileptic drug like divalproic sodium or topiramate, or what is more commonly given, somehow a stamp of vestibular migraine is put on the patient's head. Tryptamine. Tryptamine means with amitriptyline. See, or a agent for increasing blood supply to the brain is given on the basis of a artifact which was probably not even there and has come because the test has been wrongly done. So what we need to do much more is that we need to train people, train doctors to learn to do these tests properly. Because a doctor who will be doing this test, he has spent years giving those item examinations in their anatomy classes, passing through physiology, doing their anatomy and physiology, learning about pharmacology, and all those years that they have spent doing this, for them learning the test is much easier, and they are the only ones who can actually imbibe the essence of these different tests. I'll come to that if time permits. How the top of the people come out with all these wrong results with these tests, if time permits. See, now let us come to the tests. What is the standard ENG VNG test tell you? You have these are parts of the ENG VNG test. Now by this we test the oculomotor system. The biggest thing that the VNG test has been able to give us is an accurate examination of the oculomotor tests, provided it is properly done. If you have done the oculomotor tests properly, then you have gone a long way into the central vestibular system, because a lot of it comes out if you have been able to do the oculomotor tests properly. So those of you who have a VNG machine, please spend time learning how to do these oculomotor tests properly. And for heaven's sake, do not leave this thing to your assistant or to a receptionist, or whom you think, or to a driver whom you think, I have taught him how to do this thing. And even I have not taught him. When the instrument company's technician had come to install that machine, that instrument company's technician had taught my driver or my receptionist how to do the test, and that receptionist does the test, and on the basis of that I treat my patients. Nothing can be more demeaning and more of a nuisance to the science of neurotology than that. So please, for heaven's sake, learn to do these tests yourself. These tests together will take not more than 2-3 minutes time, and if you do it, you'll be getting a wealth of information. See, I sometimes go through the videos put up by different people, including in a big way Srinivas's videos also. And till today, I go on seeing them on how Srinivas is analyzing the gaze test. What does he have to say about this neural integrator system? How that neural integrator helps in that determining the holding system. Okay, he has said this. Let me see what Amir Kheradaman in the John Hopkins University, who had been working on this, what does he say? Then what has David Z and Lee in that book on the neurology of eye movements, what have they written? Like Srinivas's thing, I can understand by hearing his lecture once. But then if I have to understand that from that Z and Lee's book, I have to read it 5 times. When I read it 5 times, then I understand. Then I get another 2% or 5% more information than what I have been able to learn from Srinivas's lecture. So you see, this is how it is. And this is what we enjoy doing. And this is what we enjoy learning. And so if you're committed to this, please do so. And you'll be able to learn these things and do these things in a correct way. And if you're not doing this in a correct way, you're deceiving yourself and making a fool of yourself in front of the patient. Please don't do it. Then standard ENG or VNG test, it evaluates the oculomotor system, the sensitivity of the lateral semicircular canals only. The structures tested are the lateral semicircular canal and the superior vestibular nerve. It helps to document eye movements during positional tests and monitor the corrective maneuvers. Good enough. It does not evaluate the utricle, saccule, anterior and posterior semicircular canals, inferior vestibular nerve. It does not tell us about it tells us about the lateral canals at speeds, which natural head at which it does not tell us the movement of the lateral canals at the speeds at which we do the head movements. It tests the lateral semicircular canal at a very, very low frequency of vestibular stimulation, which has got nothing to do with our day-to-day life. But does that mean that we dump the test? No, not so. We'll come to that again later. I'll show you why. The fallacies and limitations of the VNG test are that it is a time-consuming, cumbersome test, unpleasant for the patient. The caloric test VNG is an unphysiological test that stimulates the lateral canals with an unphysiological, unnatural stimulus and at an unnatural sensitivity of the lateral canals at frequencies below 0.005 hertz. Normal head movements are at this range. So why should we test at such a low frequency? It is important. I'm coming to that later on. Due to anatomical variations in head size and the structure of the ear, the temperature at which the endolymph of each individual will be stimulated is variable. And the structural differences between the 2 ears of the same person are also common. Hence, the caloric response is absolutely unreliable, because if we are given 7 degrees above and 7 degrees below body temperature is the water that you are giving into the ear. If you are giving water, if you are giving air, you are giving 24 degrees above. If you are giving air, if you are giving water, you are giving 7 degrees centigrade above and 7 degrees centigrade below body temperature. Do you know how much change the of the temperature takes place in the semicircular canal? It is 0.1 degree centigrade. And so if there's a variation in the structure of the 2 ears, one eardrum is thicker or something like that, or at one side the bone is a little thicker or anything, you will find that the stimulation of the endolymph in the 2 ears will be drastically different. So you'll be getting abnormal result. The test is usually not very erroneously, very erroneously done and wrongly interpreted. So that is what it is. So do we dump the VNG test? No, we don't. Why? For ease of performance, inherent limitations, lack of specificity, VNG is now being replaced by VHIT in most centers. And today, people are now saying that abhi hum VNG chhod diye hain. I am not doing VNG now. I have now got the VHIT machine. I've got the VEMP machine. I've got so many papers on VEMP. I've read this thing. I've got this machine. I'm much more modern ways I'm doing VHIT and VEMP only. That is enough. Do you know what these things are? What is the relevance of these things? See, how justified is this? Do we dump the VNG test? No, we don't. See, just go through this paper, sensitivity of the caloric test and the video head impulse test as a screening test for chronic vestibular complaints. This is a paper that had been carried out. And you see, doing these papers, they do not take much effort. We can do these things at our places only. Only thing is that we don't take the initiative of doing these things. But then these are very simple papers. This highlights of the study is that VHIT cannot serve as a substitute for the caloric testing as a screening tool for patients with vestibular dysfunction, because these tests measure different aspects of VOR. That is number one. Number two is, so just because they have the VHIT, don't think that you have been able to test what a VNG would have done. They test different parts. Then VHIT is sensitive only in the acute stage, especially in the first 5 symptomatic days. Again, let me repeat, VHIT is sensitive only in the acute stage in the first 5 symptomatic days. And out of 157 patients in their study with neurological complaints, 113 had abnormal caloric test and 41 had abnormal VHIT findings. Hence, 3 abnormal caloric tests for every abnormal VHIT finding. The probability of diagnosing a vestibular dysfunction via caloric test was 72%, whereas for VHIT, it was a mere 26%. Hence, caloric test was found to be more sensitive in diagnosing vestibular disorders. Even if you have, if those of you who have got VNGs and VHITs both together, if you test a patient of Meniere's disease, you'll find that Meniere's disease, you'll find more abnormalities in the caloric test than in the VHIT. Now, this put a blot on the companies and the instrument company, manufacturing company that sell VHIT machines. So they all huddled together and have come out with some excuses by which they explain this, that it stimulates high frequencies, this stimulates low frequencies, and that there are eddy currents in the lateral semicircular canal. None of this is tenable, is actually tenable. Let us get that thing clear first, because it will be another lecture to show you that excuse which they give why VHIT is normal and VNG is abnormal, caloric test is abnormal in Meniere's disease, it does not hold much water. Anyway, let's pass this over. So VNG test. VNG test is there to stay. So the age-old caloric test is here to stay. Then video head impulse test. I think we will not go into the VHIT much. I'll go into the VEM directly and then finish off. In the VHIT test, just let me tell you that goggle slippage is a very, very common thing, and it gives wrong results. It is not arising from the semicircular canals, less sensitive than caloric test VNG as a diagnostic tool. I am saying this, and many of you are pointing your guns at me, saying that how can a black-skinned or a brown-skinned person have the guts to say something as ridiculous as this? But then this is not what I am saying. This is what white-skinned people have said, whom you worship. It is these white-skinned people have said. I am not saying so. I know it is there. We do it in our clinics, and we know, but we don't have the guts to say so publicly. And you are all junior to me, all very close to me at heart, and I know to whom I am talking. That is why I am having the liberty of saying my mind. But then whatever I am saying is documented evidence. It is not what I am saying. And VHIT is not a good way to evaluate an unknown source of dizziness, or for that matter, as a screening test for dizziness, because it is sensitive to just a few uncommon conditions. Here again, I would love to elaborate, but then no time. So abnormal VHIT. This is Nilotpal doing VHIT in our clinic. Nilotpal is has come to us from Guwahati, and is working with us excellently. And I see a budding neurologist in him, which gives me immense pleasure. See, in this VHIT, you see, you will find that the amount of VOR gain is much more than 1. In the lateral canals, it is 1.31 over here, and it is 1.27 over here, which means that the eye movement has been much more than the head movement, which is not possible. How, when you are, what do you test by VHIT? That when you are turning your head to the right, eyes will move to the left at a certain speed. But the speed or the amount of eye movement can never exceed that of the head movement. It has to be 80% to 100%. But here it is finding much higher, which means that the eyes have moved much faster and much higher than the head, which is not feasible, which is not practicable. So this has happened because the goggles was loosely fitted, and that is why you have got a finding like this. Now, when the patient has come to you with a report, you don't even know the person who has done this. Here I know that, okay, I have a reliable guy to do it, because this is Nilotpal. He's a very, very, very reliable guy, and he's holding the patient's head with a very safe pair of hands, reliable hands. But then usually it is not that. You won't have the advantage, or you won't have the privilege of having somebody like him to do the test. And so if that is not there, then how much you should believe in these tests is questionable. Then subjective, visual, vertical. Here also, there are too many fallacies, too many fallacies. If the patient's head is not perfectly vertical, just tilted slightly to one side while the test is being done, results will become wrong. Then, so there are lots of fallacies. Then if the room is not completely dark, and if the patient has not been able to put those tunneled vision goggles by which you can see only the middle of it, only the middle of the screen without any references, the test becomes fallacious. So this test also is usually fallacious, usually, if not always. Then see, a slight tilt to one side will make this thing abnormal, because if the head is slightly tilted, then our sense of verticality changes. So somebody has to hold the head from behind or something like that. Now coming to the VEM test, this has become a very common test. I will not say much on the VEM test. It is said that cervical VEM tests the sacule and the ocular VEM tests the utricle. The cervical VEM tests the sacule and the ocular VEM tests the utricle. but there are too many fallacies. Cervical VEM is only valid if it is a rectified VEM. That is, the pre-stimulus contraction of this of the sternocleidomastoid muscle is identical on both sides. In 99% of the cases where VEM is done, it is an unrectified VEM, because the contraction of the sternocleidomastoid muscle on both sides are not measured during the test. And until you specify in your prescription that only a rectified VEM report will be accepted, the person who will be doing, the third party who will be doing the test for you, will be doing a rectified VEM. Will be doing an unrectified VEM. So do not accept an unrectified VEM. You can make out from the report whether it's a rectified VEM or an unrectified VEM. I don't have the time to go into that. Asymmetrical placement of the electrodes on the sternocleidomastoid or on the inferior oblique muscle invalidates the test and presents erroneous results. Asymmetric airborne gap between the 2 ears or any mild conductive deafness in 1 ear produces wrong results. And it has been opined by experts, mind this language, it has been opined by experts as an unreliable, my mistake over here is that I put it in small letters. It should have been in capital letters, bold letters. Opined by experts as an unreliable test of otolithic function, class U evidence of otolithic function. And this again is not from what I am saying. This again is from white skinned people, and that I'll just show you that paper and then we will finish. I'll get you rid of this. See here, when the test is being done on the right side, the patient has moved the head quite a bit to the right, and the sternocleidomastoid is quite taut. Here, the sternocleidomastoid muscle is not that taut, and that is why the VEM is showing abnormal findings over here. And these things, who can test this until a clinician himself, a doctor himself trained in neurotology, who understands what difference this stiffness of the sternocleidomastoid can have between the two sides. Only he can understand. And the person who is doing the test himself, if he's the doctor, then only he'll be able to make out from here. Then, see, this is how a ocular VEM is done. The patient has to look 30 degrees above. Now, if this is how a normal thing has come. If while doing the test, the patient slightly lowers the eyes, the complete test will be lost. And the patient has lowered the eyes, the entire graph will go away. And then you'll be getting something like this. So you have to look, and it is the clinician's job. The clinician has to look into this. Otherwise, you will think that if you send a patient somewhere and you get a report like that, and you'll give the report will come that bilateral utricular failure. Whereas it is a procedural error. So these are things. A small airborne gap like this can cause a wrong VEM. See here, the small airborne gap on the left side has caused a small VEM over here. So the audiometry test has to be done, and more than 10 decibels of airborne gap difference is over there on the two sides. Then you should not advise a cervical vamp, a vamp on that patient. So this is what I was wanting to show you. These are practice guidelines brought out by the American Academy of Neurology. They bring out practice guidelines, and this practice guidelines was on the relevance of ocular vestibular evoked myogenic potential test for clinical practice. There they found that this VEMP test is only useful for diagnosing superior semicerebral canal dehiscence. Other than that, it is useless. And they have shown over here in this study, please, this is a open paper, open access paper, and all of you can diagnose it, can always download it. And so before advising VEMP left, right, and center, and before thinking that a VEMP has been able to diagnose your this person's disease, please remember one thing, that this was a huge committee in which some of the big names you have all heard, like Terry Fife, then Michael Stroop, then a lot of these are very, very big names. And they have opined that this is a class U evidence. Class U evidence means it does not, there is not enough of evidence to show that cervical vamp evaluates saccular function and this ocular vamp evaluates the utricular function. So that is there. I cannot go into further details. So inconsistent in vamp. So over the ages, you'll find that initially they used to get that you can diagnose vamp by meniasis by vamp, you can diagnose meniasis by vamp, but later studies started showing that no, it cannot be diagnosed. If we don't have time to go into that, otherwise I have a presentation on vamp in Meniere's disease where I can show that how during the ages how this thought has changed. Meniere's disease indicating that the tests are fallacious. This is cebulometry. We are not going to that. However, all vestibulometric tests are only as good as the man behind the machine. Most tests are very vestibulometry unreliable and irrelevant to clinicians today. Clinicians should never accept a vestibulometry test until it has been performed and authenticated by a medical person with sufficient clinical knowledge and insight in vestibular physiology. So these are the tests that we get in our clinic. People come here and then. So vestibulometry does not evaluate the vestibular labyrinth at all frequencies. Normal findings in all tests does not mean that there is no defect in the vestibular labyrinth. Test procedures are extremely prone to errors. Hence, abnormal test findings do not necessarily mean that an organ is defective. Wrong reports are very common and misleading. Tests are not foolproof. Site of origin of measured response is controversial in many tests. Like in VEMP test, we do not even know today for sure whether the in ocular vamp comes from the utricle only or from other places. In subjective visual vertical, we have no proof that subjective visual vertical actually tests the utricle or some other part of the system. So, so the vestibulometry, so from the site of origin of the test is not known, is not 100% proved. Vestibulometry evaluates only vestibular labyrinth and a few associated systems. Balance disorders can be caused by extravestibular defects in a large number of patients. The tests are meaningless if not analyzed in light of clinical findings, and tests do not identify the nature of the pathology, hence useless for deciding treatment, only identifies this. So this is it. It cannot, vestibulometry today can diagnose the site of lesion of a lesion with utmost precision and accuracy, provided it is done by the right person, and the nature of the pathology which is necessary for treatment. Interpretive tests are history and only by a disorders, not by a glorified switch pressure. Clear about this? So thank you, but only if you agree that these vestibulometric tests are irrelevant, if not a nuisance in clinical practice, provided it is not done by you yourself, and if it is not analyzed in the light of clinical history and the clinical findings. Vestibulometric tests are useful only if they are properly done and interpreted by an expert in the light of history and the clinical findings. So thank you. I'm sorry for taking a long time. I believe, but then just before the meeting, will not be coming because she has got some duty. Paramita, I would have loved over here, so I extended my presentation a little bit. Okay. So back to Gautam, back to Surajit, and to our chief, Srinivas.
Sir, thank you very much, sir. It was wonderful and comprehensive review, both from the clinical aspect and the investigation aspect. You told you will talk only the cons, but you spoke both pros and cons.
No. So I hope people are not pointing their guns at me.
No. Everybody is happy. Everybody is happy about anything truth. Okay, sir. Yes.
Okay, Srinivas. Thank you very much.
Thank you, sir. Thank you, sir. Thank you, sir.
So I am stopping my video and unmuting myself. Okay.
Yes. Thank you.
All the talks will be available on the net after the series is over. People like Paramita, if somebody who has missed the talk, can definitely watch it later as well.
So, Ajay, by the way, if anybody has any questions, is there any forum to answer the questions later on?
Yes, sir.
Or you can email it to me. I can also send you the answer, because you may require references. You may require any questions ready to answer. Let me know and I'll be very happy. Okay.
So we'll have a question answer session at 8:30 in the evening after all the talks are over, sir.
Great. Okay.
So thank you very much, sir. And now the next talk. Before giving the next talk, I'd like to introduce the speaker of the next talk. The speaker is Dr. Srinivas Dorasala. He is the chief faculty of today. So his present position is co-founder, director, product innovation, Cyclops Meditech Private Limited, Bangalore. He had been previously senior consultant in ENT, BGS Global Hospital, associate professor, MS Ramaya Medical College. His academic qualification, MBBS 1999 and MS April 2006. He has numerous publications. His special interest, we all know, is vertigo and balance disorder, with special expertise in video nystagmography. Awards and recognitions are too long to mention. He has guided doctoral projects on piezoelectric sensing based on device for non-invasive assessment of nasal flow in Indian Institute of Science. Postgraduate project guided for BMS College of Engineering and MS Ramaya Institute of Technology. So before handing over the mic to Dr. Srinivas, I'd like to mention, if in our initial program, his talk was on physiology of the balance system. However, because of certain personal problem, Dr. Paramita could not join us today. And Srinivas sir has very enthusiastically accepted to also talk about the anatomy, include that part also in his talk on physiology. And after the anatomy and physiology talk, he will go on and give his take on history taking in vertigo, because unfortunately, because of the death of Dr. Hitesh Shah, Dr. Hitesh Patel could not join us today. So with this, over to Dr. Srinivas for his talk.
Thank you very much for the opportunity again, Dr. Surajit and Dr. Gautam Khan sir. So it's always a pleasure to meet you all the time. Okay, I'm always eagerly waiting for an opportunity. And so today I'll straight away head to the talk. Okay. And I thank Dr. Anirban Vishwa sir for blessing us and being the teacher for all of us in the science of in the vestibular and balance disorder science. So I'll start sharing the screen. Okay, I'll share the desktop itself. Okay. I hope you are able to see the slides.
Yes.
Yes.
Okay. So, yeah. So how do we balance? And then a part of anatomy, a part of physiology, whatever it is, so that we understand how the exact mechanism of inner ear encoding for balance happens, I'm going to do. Okay. Before proceeding, This talk of mine is dedicated to the fond memory of our friend, Dr. Hitesh Shah. Okay, a man who thought high, is compassionate doctor. He gave books as gifts to all people. Okay, and that was his way of receiving friends and giving compliments, whatever it is. He used to give books as gifts. That's a big, big thing. He's a gifted poet and writer. He had just a few days ago, just not less than a week ago, published his latest book in Gujarati. Okay, never knew any malice towards anybody. That is the word that anybody, Dr. Bijlani used in the morning to describe him, which is very apt about him. He's a great companion and an excellent human being. Okay, and only people who have dealt with him, who have been close with him, know what a big loss it is that he's not among us. Okay, a great, great person. And we in fact, we are all very disturbed by his loss, but then we have to carry on with works. So we are going ahead. Okay, so when it comes to if there is any voice issue or anything, please let me know, somebody. Okay, otherwise I'll think if there is no message to me, please stop me, because I'll not be following the chat. Okay, so if there is any issue, please stop and intervene in a voice message. Okay, so I'll go ahead with the anatomy physiology simultaneously. Okay, so what happens is, to understand the vestibular system, the key thing that we need to understand is the hair cell. Okay, once we have a clear understanding of what this hair cell is, a lot of the things will start falling in place, and therefore I'm going to deal with the hair cell. What you're seeing here on the left side is the hair cell, just schematic picture. But what you see on the right side, which is marked B here, is an electron microscopic picture of the hair cell. And when you look at this electronic microscopic picture of hair cell, hair bundles on top, you see one big structure coming up that is called the kinocilium. And there are multiple bundles, hair bundles that are there. I mean, there are multiple hair that are vestibular hair cells with this thing. So there are a lot of these things which are projecting upwards. Okay, which are projecting in a ascending and an arrangement in a order of height or something like that. Now, if you take a square cut and then make it big, what you see in the hair cell is that there is the hair cell, and from one hair cell to other cell, one other to other hair cell, there is something like a rope that attaches. So this is the tip link. So if you schematize these two things, the big kinocilium will come here, and multiple hair cells in order come there, and these rope-like links are here as the tip links. So these structures are called the stereocilia. Okay, multiple, each of these projections is called the stereocilia, and the big thing is called the kinocilium. So, and down here, the nerve makes a synaptic connection with the hair cell, and this is the scheme. So let us go to what exactly is this and why understanding this is very, very important. Okay, so when you go into that in a cross section or something like that, you see that, okay, this is how the arrangement is there. There is the kinocilium on one side, and there's multiple rows of the hairs. And this one, if you see here, what is marked as K is the hair cell. This is another picture. And on this side, you see there are tip links that are marked. Some run from side to side, and some run from one row to the next row. So, like within the row, there are links, and then there are row to row, there are links. So there are two kinds of links. So hair cells can move in this direction or in this direction, but there is a difference between what happens inside the hair cell when it is moving up and down versus when it is moving front and back. Okay, I'll come to that a little in the next slide. Okay, so when you came to the hair cell in the first diagram, we saw this particular thing, the rope-like thing that is attached from one hair cell to the other, or one hair cell to the one stereocilia to the other stereocilia, all the way up to the kinocilium. So if you go close, what do we see there? If you go close, this particular rope-like thing, okay, that tip link, these are made of a protein called cadherin. So that protein is the one that goes from one to the other. So this is the one. What is it? Okay, what does it do? Here in the gross picture, it just looks like it is going from one stereocilia to another stereocilia. But one stereocilia to another stereocilia, where does it go is very, very important. So when you look inside from one stereocilia to other stereocilia, it is actually guarding the opening of some ion channels. So it is guarding the opening of some ion channels. So what is going to happen if this spring-like protein is guarding the opening of the ion channels? What happens? What happens is, when there is a movement of the kinocilium in one direction, there is going to be a pull on this Catherine channel. So there is going to be a pull here. When this pulls, it pulls on the doors that are guarding these channels. So what will happen if there is a pull and this moves in one direction? The spring pulls is pulled apart. So if it is pulled apart, the channels, doors of the channels open up. What will happen if the kinocilium moves in the other direction? If it moves in the other direction, there is a spring action, spring back, whatever it is, it will close. Okay, so it will close. So if it closes in one direction, it will close in the other direction. It is pulled open. If it moves in one direction, these channels close. So what is going to happen by this opening and closing of the channels? So if the channels open up, ions enter through the channels and get into the stereocilia and cause changes within the hair cell. When they cause changes within the hair cell, there are going to be next level of activities. There is something called basolateral currents that come up. And then secondary to that, what is going to happen is that there is going to be synaptic release, and that synaptic release is what is going to be conveyed as the action potential. So that is what is going to happen. So this is the key thing. There is a hair cell with a specific purpose, and that hair cell can get excited or can get inhibited. Now we need to understand one concept of what is this excitation versus inhibition. So when you saw this particular channel, okay, when the hair cells are straight like this, these channels are not neither closed nor open. They are half open. Okay, they are not completely open nor closed. So they are partially open. Partially means, actually the word that I used, the half, is actually not correct. They are just open. Okay, they are just open. So if you pull the hair cell in one direction, in the direction of excitation, as is mentioned here, when it is pulled in one direction, that is the direction of excitation, the hair cell opens up. I mean, the channels open up more. If it is in the direction of inhibition, what will happen is the channels will, they are only partially open, they'll snap close. That is all. So what it means is, in the direction of excitation, if it is partially open, little bit of movement in this direction or whatever, in the direction that you are seeing on the screen, maybe like this. So little bit, it opens so much. A little bit more, it opens more. A little bit more, the channel opens more. A little bit more, the channel opens much more. In the direction of inhibition, a little bit in the other direction, it closes. A little more, it is still closed. A little more, it is still closed. A little more, it is still closed. What does it mean? For excitation, there is a huge dynamic range. Whereas for inhibition, the dynamic range is very, very minimal. So this much we should know. Okay. Now from here, I will just go on to where all this hair cell thing is applied. This is simple, hair cell. Now we have to use this particular hair cell, which has one property. If it moves in one direction versus the other direction, it can get excited or it can get inhibited. So what we are going to do inside now is try to understand how this one particular thing, which can just encode movement of the hairs from this side to this side, can be used to assess gravity, can be used to assess linear acceleration, and then tell which exact direction of linear acceleration, and then also tell the rotational acceleration, all based on simple this thing. When it comes to, this is the biological construction. To similarly build an artificial construction, that engineering construction, still we are don't have that perfect, okay, in the sense we do for aviation, for all these things, but this matches any of those things in its versatility, in its just the sheer idea or the sheer whatever it is you want to call it, as a genius that goes into making something like this. Okay, so I'll do that. Now what is this? Okay, what you're seeing me is, I mean, this is a very favorite picture I keep using all the time. Okay, what we are trying to do is, this is the mason's plumb bob. So the mason's plumb bob is the equipment used by the mason to make sure that the buildings that he's constructing, that the walls that he's constructing are actually constructed vertically. So when he's trying to make sure that the walls that he's constructing are actually built vertically, what does he use? He uses a heavy thing, okay, iron, okay, which is almost circular in this fashion, and then it is suspended. So it's suspended from a thread. So when the heavy thing is heavy iron is suspended with a thread, we know that the thread will always take a position which is going to be in line with the gravity vertical, in line with the gravity vertical. So what does the mason use to find out the gravity vertical, or what exactly is the line of gravity? He uses something heavy. Okay, so that is the mason's idea. So what does the body do? Okay, from the earliest otolith, graviceptors, even in water-dwelling life also, there's a concept of graviceptors to find out which is the line of gravity. So what principle that graviceptors use to find out the line of gravity is again to use something very, very heavy. So in this picture, what you are seeing is that there are nerve fibers, there are hair cells, and then, of course, there are the stereocilia and all those things, and kinocilia, everything projected into a gelatinous matrix. But on top of the gelatin matrix, what you're seeing there is actually calcium carbonate crystals. So what you're seeing there is calcium carbonate crystals. What do these calcium carbonate crystals do? These calcium carbonate crystals give this weight. Weight suspended on something here. Weight suspended on top of here, weight suspended from something here, something heavy suspended on top of a membrane. So basically it behaves similarly. It tried to get pulled in the direction. It tries to get pulled in the direction of the pull of the gravity. But when you see this particular membrane here itself, the underlying structure, if you see the fine collagen structure or molecular structure there, it is in such a way that they are all vertical columns down in this gelatinous matrix, that it doesn't collapse or get compressed from up. It doesn't get compressed from down. So what will happen if this is the uticular membrane? Okay, I hope you are able to see. And these are the hair cells. On top of the hair cells is this calcium, calcium carbonate crystals. They don't compress this into collapse. So they stay like that. So when they get activated when there is a tilt. So if there is a tilt, they pull to one side. If there is a tilt like this, if it is straight like this, it's okay. On the hairs, there are calcium carbonate crystals, whatever on the gelatinous matrix. It can't compress, but if it turns, then it gets pulled in the direction of the gravity. It gets pulled in the direction of gravity, whichever side that is. So this is how the otoconia help in making this responsive to gravity. But then how do you find out what is the line of gravity from this simple mechanism? First, we saw how the hair cell, when it turns, when the hair cell is moved in one direction or the other direction, that there is an increase in activity or the decrease in the activity of the nerve cell by allowing the ions to enter by the channels being open or by channels being closed. That we saw. Now we are seeing we are putting something heavy on the otoconia, and that otoconia will ensure that this movement of the hair cell is actually now happening in relation to or with respect to gravity. That is one. Now line of gravity, how much tilt, how does it happen, or linear acceleration also, how does it happen, is what we are going to come to. Okay. So before that, what we need to see is this concept called morphological polarization. The first concept we saw is the concept of a hair cell, hair bundle, which controls the opening and closing of ion channels and thus the opening and closing of the action potentials. That's the increase or decrease in the number of action potentials. Number 1 point. Number 2 point that we saw is in the something heavy can make something responsive to gravity. So the otoconial particles, the calcium carbonate crystals make the utricle, okay, or the otolith organ, the hair cells there move in response to gravity. Okay, now next thing is, for detailed understanding, we need to know another concept called morphological polarization. What is morphological polarization is, there is a certain way of arrangement of adjacent hair cells. Okay, we saw one bundle of stereocilia, kinocilia. Yes, they are all in one direction. But if you see multiple bundles and if you see the structure, there is a certain way in which they are all organized. Okay, it is not haywire. It is not like one kinocilium is facing in one direction, another kinocilium is facing in the other direction. You can see here this kinocilium is facing West means this is also west, this is also west, this is also west. So that kind of a group arrangement of multiple hair cells is there. Okay. Okay. So there is some order to this arrangement of adjacent hair cells. So this is called as concept of morphological polarization. Now we will build using this morphological polarization. Okay. Another concept. Okay. If you see the utricle and saccular macula, okay, there is a central line that is called as striola. Okay. There is a central line which passes all across. There is a striola. So across this striola, the morphological polarization becomes opposite. So on one side, the kinocilium, or see here you saw in the previous diagram, all the kinocelia are westward, 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 or whatever it is. Okay. Now here, if you see this striola, if this is all westward morphological polarization of the kinocelia, just if you cross over from one side to the other side of the striola, all the morphological polarization is towards the east side of the kinocilium. So this is another concept. Now we will build next one more. Okay. But when you see the striola in a more detail from the top like that, okay, view, okay, of the utriculus or of the saccule, you see that this striola is not exactly a straight line, but it is actually a curved line. Okay, I hope you are able to see my cursor. So it is actually a curved line, and across the curved line, the morphological polarization is towards that line. So here, if it is west, here it is actually north. So you see from west to north, slowly it changes. Here, if it is east, here it is actually south. Okay, east, southeast, and south. So there is a change according to that line. Okay, this is another beautiful concept of morphological polarization. Now we need to see one more beautiful. So this morphological polarization in a little bit of detail. So in the saccule, it runs like this. In the utricle, it is like this. And when it comes to the semicircular canal crista, all of them are in one direction. See here, all of them are in one direction. In the saccule, okay, and you know, in the saccule, it is away from the striola, whereas in the utricle, the morphological polarization is towards the striola, this much. Okay. Now we have to come to another concept. When we saw the hair cell, I showed you one concept about the hair cell here. When we saw the hair cell, okay, there were two different kinds of hair connections, interconnections between stereocilia. So there are multiple rows of stereocilia, 1, 2, multiple rows. So there were connections between the taller row to the shorter row, that is this kind of connection. And there were connections from the same level, at the same level, means connecting this to this, this to this, this to this. Okay, like that. Both, all of them were there. Okay, look at me because I'm demonstrating something with my hand. So there are higher row to the shorter row, a bigger row to the shorter row. There are connections, and within the same row there are connections. Now what happens is there is a key difference. I showed a diagram of a cadherin channel, and I showed the diagram of a channel, cadherin protein, which is the rope or the tip link, which is connecting from one level to the other level and going into the ion channel. So that one is attached to the ion channels. Whereas from this side to this side, that kind of a connection is not there. So what will happen if the hair cell moves like this? There is no opening or closing of the ion channels. But if the hair cell moves like this, there is opening and closing, means it is going to pull and the ion channels open up. But if they move like this, there is no closing and opening of the ion channels. So what I mean, if you look at the diagram here, this is the kinocilium. So if there is a movement in this direction, in this plane, so this way or this way, there is opening and closing of the ion channels because those cadherins are into the ion channels. Whereas if it moves like this mass action, okay, just in the opposite direction, just 90 degrees to it, there is not going to be opening and closing of the channels. Okay, that is the behavior. So there is a study, to show how is the response characteristics. So you can see the response characteristics of this one. So exactly at 0 degree versus 90 degrees to that line. At 0 degrees to the line, the maximum amount of excitation and inhibition, that is opening and closing of the channels happen. 90 degrees to that axis of kinocilium, that axis, okay, if this is like this, okay, short, long, if it moves like this, at 0 degree, maximum excitation and inhibition, at the maximum opening and closing of the channels happen. At this, there is absolutely no opening and closing of the channels. this is very important for us to understand the next detail. Okay. So that next detail is this. Okay. So just imagine, in the beginning we were talking about how that particular utricle or whatever can tell that you have tilted and in which plane you have tilted. How the utricle can tell whether I have tilted like this or I have tilted like this or whatever. So how the utricle can tell that? We know when there is a tilt on the whatever the carbonate crystals are there, they pull the hair bundle. We know that. We have seen all that in the detailed anatomy that we went through, that we know. But now the utricle has to tell which exact direction. So all the things that we just till now discussed are going to come together. So just imagine, see, look at this utricle. So, and see here, this is north and south. Okay, these hair cells are north and south. The arrow here, okay, those hair cells. Here are hair cells, they are east and west. Now imagine what will happen for a particular tilt. If this one tilts, okay, this particular utricle, whatever is there, if that utricle with the hair bundles, whatever it is, it tilts in one direction. If it tilts in one direction, all the hair bundles will sag towards the earth. All the hair bundles there will sag towards the earth only. So that is no issue. But all of them hair bundles will sag towards the earth. But what will happen? The hair bundles that are here, their distortion is actually in the kinocilium in this order. So they are going to open or close the channels. Whereas the hair cells in another area, just 90 degrees to that, the hair cells that are situated in that place, they also get distorted, but though they don't get stimulated or inhibited. They get distorted, but their distortion is in another plane. See, for one place hair cells, the distortion is where the one row to other row, that plane. So what will happen? The ion channels open. Whereas just 90 degrees to that, they get distorted in this plane. So there the channels are not opening up. So what happens is, for any particular tilt, there is one particular place at that point. That is the point at which there is a maximum stimulation of the hair cell or inhibition of the hair cell by opening or closing of the channel. And exactly 90 degrees to that, there is absolutely no opening or closing of the ion channels in the hair cell. So I'm talking about, okay, these ion channels. So these ion channels. So if they are moving in this one particular plane, so if they are moving in this back here, those ion channels open up. But if they are moving in this plane, they don't open up. So only this plane, they open up. So that is how it happens. Now you know what will happen here because of this. So if there is a tilt forward, if these hair cells are getting maximally stimulated, these hair cells are getting least stimulated or at a zero level of activity. So for every level of tilt, like if you're tilting like this, there is going to be one point where there is maximum tilt. If you're tilting like this, there is going to be another point. If you're tilting obliquely, there is going to be another point. So for every point, there is going to be one particular area where one hair cell is maximum. So based on this map, okay, just like there is a tonotopic map in the cochlea, there is a spatial map in the retina. Just like that, there is a map in this utricle and saccule. So based on which area the stimulation is maximum, it knows that the tilt has been in this particular direction. The same thing can also be applied for translations. So the utricle, if it responds to tilt and it starts sagging down, anything heavy on one thing and the base moves, the heavy thing has inertia and it will stay where it is. So that also will distort the hair cell. So based on that, the utricle and saccule can also detect linear accelerations from one place to the other place. So I think this much is clear. Dr. Surajit, if there is anything that I need to slow down or make it fast, please let me know. Okay. Okay. I'll be depending on you for feedback, live feedback. Okay.
Sure, sir. It's going fine. Fantastic, sir.
Thank you. Thank you. So now what we are going to do here is, so this is the another diagrammatic representation of how the utricle and saccule are placed. So utricle on the top is more horizontal and the saccule is more vertically placed. Now I want to come to, so now we know, we saw the hair cell. We saw how the hair cell distortion leads to increase and decrease of the action potential by opening and closing the ion channels. We also saw how something heavy can be used to detect the line of gravity. And we also saw how the exact line of tilt, okay, the plane at which you are tilting the head can be detected by the strialar arrangement and different hair cells being sensitive at different places. Now, the next thing is we are going to do is that how to make a hair cell, which is basically, it detects distortion of that one, this plane or whatever it is. So basically it's a linear sensor of, it's a sensor of linear distortion. How can you use a hair cell, which is basically a sensor of linear distortion, and make it something that can actually detect circular motion or rotational acceleration? So this is another beautiful construct, okay, beautiful construct. Even by the best of engineering, this is a totally different way, and none of the gyros that I am aware of which are built use this particular principle. Okay, these are totally beautiful this thing which biology has chosen to give it, which till now has not been adopted by engineers. So this is a beautiful principle. Okay, so now just imagine you are having one particular, okay, stick with something heavy on top of it, and it is free. It is free. You shake in any direction, it moves in this particular direction. You shake it front and back, like if you're sitting in the bus. Okay, just imagine yourself standing in the bus or whatever it is. If bus goes front, you go back. If bus goes suddenly applies a brake, you fall back. If bus swerves to one direction, you fall to this direction. If bus swerves in the opposite direction, you fall in the other direction. So, but basically you are swerving with respect to, okay, forces which are acceleration forces, deceleration forces, rightward swerving, leftward swerving kind of forces. Now this is like, okay, in any direction, okay, any direction, you are becoming responsive. If your movement is considered as a response, you are responsive in any particular direction. But some amount of direction specificity came to that movement also, because the hair cell itself responds to movement in one plane and does not respond to movement in the other plane. So if the person who is sitting in the bus is a hair cell, he can be one person who is responding to accelerations and decelerations, but he gets distorted for swaying to right, right turns and left turns, but he does not stimulate the action potential or in the nerve. So if the person is considered as the hair cell, that way one line is considered, but still that is linear acceleration. How do you make his distortion or his movement only happen when the bus is rotating like this or like this, only that thing? That is the beautiful construct that has come in the semicircular canal. So how do you do that? You place this hair cell at the end of one circle. You take one semicircle, it is called a semicircle, but it's almost a complete circle with a little opening. So you take that, and into one end, you place a cupola, okay, a big cupola, and then the hair cells on top of it with morphological polarization, all of them, all the kinocilia are to one particular direction. So what will happen at that time? And this cupola diaphragm that is there, that you see here, this is a complete diaphragm. From one end to the other end, the cupola is a complete diaphragm. Okay, if time permits, I will show you the diagram of real pictures of this one, where it is a complete diaphragm. What does it mean by complete diaphragm? Whatever comes here cannot cross over to this side. Whatever is here cannot cross over to the opposite side. Okay, this is an anatomical fact that we need to keep in mind, because if there is a debris on one side in treatment of benign paroxysmal positional vertigo, you cannot force it across this one. It has to go all the way around and then come and fall into the utricle. For that reason, we should know that this cupola is a complete diaphragm. Okay. Now, so this is being placed here. So what will happen if you place here? So you see the arrangement, the neuroepithelium, there is a crystal, all the hair cells are in morphologically polarized to one particular side. All that is fine. Okay. So what will happen now? This one now no longer responds to. What happens is, if it moves straight, okay, if it moves straight like this, if it moves straight in one plane rather than a rotation, if it moves straight, what will happen is, there is going to be fluid going in this direction. There is going to be fluid. Let me use an annotation tool. Okay. So what will happen if it was a cube, and within that, if this cube was made to move in this plane, what will happen is all the forces will act in one direction. Okay, all the forces will act in one particular direction, and that means all the hair cells will get distorted in one particular direction. That is what is going to happen in the utricle and saccule, is what is going to happen, and they are responsive to linear acceleration. Whereas when it comes to when it comes to the semicircular canal, there is something else that happens. Okay, there is a book called The Vestibular System, A Sixth Sense. It's a red book. Okay, for anybody who wants to go deep and into vestibular science, we should be reading that particular book. Okay, The Vestibular System, A Sixth Sense. So this concept is there. So what happens is, see, in this particular place, if it moves like this, okay, if it moves like this, okay, so in this particular place, the fluid lags behind like this. In this particular place, the fluid goes like this. Ultimately, the forces cancel out. Okay, what the fluid is moving here and the what fluid is moving here, the amount of force, whatever it is, they cancel out on this half of the limb versus that half of the limb. They cancel out, and there is not going to be any net force, okay, experienced by this cupola. Okay, they cancel out if there is a linear acceleration. That is the beauty of this construction, why nature chose a canal which is like a circle to do this particular thing. Whereas if it makes a circular movement, then the force that is encountered by the fluid here versus the force that is encountered by the fluid here, they add up. Okay, if it makes a linear movement, they minus. Okay, if it makes a linear movement on one side of the semicircle versus the opposite side of the semicircle, along this circle, meet and they minus, these forces minus. Okay, for exact physics calculations and all those things, again, we have more mathematical books, but I'm just giving the overall concept and intuitive concept from the higher level. Whereas if it rotates, the force experienced by the fluid here and the here are in the same direction. Okay, so this is the beauty. Now what happens? The hair cell that is there in one particular place, which was basically by its construction just a detector of distortion. On the utricle, it was a distortion which could detect gravity and linear acceleration. Suddenly that has now become a detector of rotational acceleration just because of the geometrical construction of the semicircular canal. And see the beauty with which nature has given rise to a rotational sensor just based out of the same thing. So we had the same hair cell, the same one hair cell in the cochlea becomes a detector of sound. The same hair cell becomes, in the cochlea there are some anatomical differences of the hair cell, but it's a detector of sound. The same hair cell which just encodes distortion becomes a detector of gravity related tilt in the utricle and saccule, and also linear acceleration in the utricle and saccule. And that same hair cell here in the semicircular canal becomes a detector of rotation. Okay, so this is the beauty. Okay, so when you saw that, then there is one more thing. Okay, there is a direction about each semicircular canal. When you see the semicircular canal, so when you do the rotation, so along the plane, so if this is the plane of the semicircular canal, if you do the rotation in the plane, so what is going to happen in the plane is that there is going to be maximal movement of the fluid or maximum force encountered by the fluid. But if you do it just 90 degrees to that, then there are walls, and there is not going to be much of a force that is encountered by the fluid column because it is stopped there itself. So because of this, what happens? Each semicircular canal has one axis around which, if there is one axis around which it can be maximally stimulated, there is another axis around which there is absolutely no stimulation. So if the semicircular canal is like this axis does not give any stimulation, but this will give maximal stimulation. So what happens is the semicircular canal now is not just a detector of rotation, but it is a detector of rotation around a particular axis or along a particular plane. So it becomes like that. So this gives a specificity of the semicircular canal's detection. So that is why what happens here is the semicircular canal becomes very specific. And because it is very, very specific, the semicircular canal, you need totally for representing in the 3 dimensions. If you have to suspect, there's a need for totally 3 vectors or 6 vectors. So for that, what you have, you need 3 semicircular canals, and each of the 3 semicircular canals, to be able to best detect the direction in any rotation in any plane, you need them to be orthogonally placed, means 90 degrees to one another. So that is why this kind of a arrangement has come in the semicircular canal. So this is the physiology, the underlying physiology of this thing happens. Okay, so so this is some amount of microanatomy and some amount of microphysiology. Okay, now coming to some of the core concepts. Okay, some of the core concepts when it comes to vestibular physiology. Surajit, how much time I have? Dr. Surajit?
Yes, you have another, because this was supposed to end at 7:20. So you have another 8-9 minutes for this. Then you have the history talk. So you need to complete everything by 8:28.
So what I will do is I will convey some 3-4 core concepts based on this one, and then we will have Pratik to present. Okay, so there is no monotony, and then after that I will do the history. Okay.
Sure.
Okay. Fine. So now coming to, based on all these things, there are some concepts that we can do. Okay. So what was happening is we saw 2 different kinds of structures here. Okay. One was the otolith organ. Okay. One was the otolith organ. So otolith organ became a detector of gravity for a particular reason, because there are something heavy particles here. And when it comes to the semicircular canal, it is a detector of flotation because of its geometrical arrangement. So semicircular canal is not meant to do something. What it is not meant to do, the semicircular canal is not meant to detect gravity. So semicircular canal distortion should not happen in response to gravity. So if at all this autoconial particle become loose from in this particular place, and then they go and sit in the semicircular canal, if they go and sit in the semicircular canal, what will happen is there is going to be mass movement within the semicircular canal. Okay, so there is going to be mass movement within the semicircular canal. Fluid movement is brought about in relation because of a gravity related action. Okay, not because of rotation, but because of a gravity related action, it will start moving from one place to another place. Like if a debris is placed in one place, there's a detailed session on BPPV by Bijlani sir, but then I'm just telling. So if there is a debris in one particular place, because of gravity related forces, this debris moves from one place to another place when the head position changes. This is not because of rotation, but because of gravity. So hair cell does not know why this particular thing is happening. So because the hair cell does not know why this particular movement is happening, it just knows that it is getting distorted. So when the hair cell knows that it is getting distorted, all that it does is it just gives the action potential. So when the brain and the remaining part of the connectivity, when they see that the action potential is coming from the semicircular canal, the brain thinks, the brainstem thinks the message conveyed is that actually the person is rotating, and in response there is going to be eye movement and there is going to be a perception of rotation. So that is one category of problems called as aberrant stimulation. Then there is one more problem which happens, and that particular problem that happens is where the semicircular canal, okay, the bony canal is exposed. Okay, the bony canal is exposed. I mean, the bony canal is no longer protecting the semicircular canal. Okay, the bony canal is not there, so it is gone off. So what happens is, if the dura mater or whatever it is making direct contact with the canal, so what will happen if there is a change in the pressure intracranially, whatever it is, that pressure change is transmitted onto the canal duct. So when the pressure change is transmitted onto the canal duct, what happens is there is going to be a pumping like action. It's like a pump action. So when something like a pump action happens on this, because of the dura, whatever, if you try to weigh, okay, this is the superior canal dehiscence syndrome. When there is that pump like of action, there is going to be a fluid movement here. So that fluid movement is going to cause the distortion of the cupola here. If it's going to cause the distortion of the cupola, again, the brain does not know that it is because of a break in the bone. The brain thinks if the semicircular canal is sending the action potential, it is sending the action potential for a specific reason, that the person is actually tumbling or going around, and there is going to be an appropriate eye movement response. The other rule that we need to know is there is a, okay, I need to, okay, recall Dr. Pradeep Pundavalli at this moment of time. From him comes these concepts of the evolutionary relationship or the developmental relationship between the semicircular canals and the extraocular muscles. So the semicircular canal planes and the extraocular muscle planes and the action of extraocular muscles also are developmentally related. So each semicircular canal actually controls a pair of extraocular muscles, one in the right eye, one in the left eye. So it does that. So because of that, what happens? Every semicircular canal produces a particular characteristic type of eye movement. So that is, so there was previously known as Fluorent's law, and okay, which we know Fluorent's findings. We know the Evol's law, which simply states that every semicircular canal, when it is stimulated, produces eye movements in the direction of that particular semicircle. Yes, perfect. It is true. Now, how does it happen? Because each semicircular canal actually innervates a particular kind of extraocular muscle. So horizontal semicircular canal bring about horizontal eye movements. The vertical canals bring about vertical eye movements, vertical and torsional eye movements, because they are not exactly in the parasagittal plane, but away from the parasagittal plane. So therefore, they bring about different kinds of eye movements. And also, right eye versus the left eye, the muscle that each semicircular canal innervates is different. Like for example, the right posterior semicircular canal actually innervates the right superior oblique and the left sided inferior rectus. So because of that, the exact eye movement you see in BPPV between the right eye and the left eye is not always the same. There is going to be some difference. So that is why we should see eye movement in both eyes to actually determine which exact plane of semicircular canals is being stimulated. So this much. So this is for introduction, both from an anatomical and a physiological perspective. At this point of time, take a break. I'll tell some other points when it comes to the vestibular system. When it comes to the vestibular system, we saw in the beginning that it is a detector of linear acceleration with respect to gravity. So it is a very nice detector of gravity related tilts of the head. So if you know your posture with respect to gravity, then it is very important for assessment of our posture. Okay, whether, I mean, not assessment of posture, to maintenance of posture. Maintenance of upright posture without falling is heavily dependent on the semicircular canals. Number one point. Second point that we all remember, we know is that semicircular canal, because it controls the eye movement, during rapid head movements, we are able to maintain a clear vision, because for every rightward head movement, there is a leftward eye correction, and for leftward eye movement, there is a rightward, whatever it is, compensatory eye correction, good vision. These are the things that are commonly known about the semicircular canal. What is not commonly known are the secondary, tertiary, other roles. One important role is the labyrinths are very important for pathfinding and spatial orientation. What is pathfinding and spatial orientation? Like navigating yourself in space, all these things. There are cells in the hippocampus and related areas called place cells, grid cells, which are very important for us to tell which direction you are heading, where you are. Even when you are sleeping, if you don't fall off the cot, or from the small railway berth, you don't fall off, that is because your space is mapped, and there is a map of your space that is created, and the boundaries of safety are marked inside, and that is working even in your sleeping state. So that for that function, the semicircular canals are very much important. Then the other thing is, for maintenance of upright posture, in our physiology classes, we have been told about the carotid sinus, we have been told about the aortic receptors, baroreceptors, everything we have been told other than our utricle and saccule. Again, utricle and saccule have very strong autonomic connections at the brainstem level, like the nucleus of tractus solitarius, okay, the motor nucleus of the vagus, and so many other things. So what happens here is that, again, when you are upright, the blood pressure maintenance and all the autonomic changes that needs to happen are, again, there is a role for the inner ear, okay, especially the otolith organ. So that is another role which was not that much recognized. Then another role that is getting recognized nowadays is in mood alteration and those kind of therapies. So we all know that a baby who is put in a cradle and is made to swing from right to left sleeps well. So it reduces the anxiety. Okay, so that is known. So semicircular canal stimulation. Then there is something else that happens. You go to the amusement park and there is again a vestibular stimulation, but that's a different kind of stimulation. It is not a slow rhythmic stimulation, but an unrhythmic stimulation, which is meant to excite you. So there are so much more about the vestibular system that is getting explored. As Dr. Anirban Mishra sir previously told about the cognitive load and cognitive impact, that is something we explored. So my brief introduction was to make I was familiar with the way the hair cell actually transduces head movement and head orientation, and with a little bit of idea as to the other potential possibilities for the vestibular system and we have exciting things waiting for us in the next 2 days also. I think with that I end my first talk, and may I now request Dr. Surajit to take over.
Thank you very much, Dr. Srinivasa. It was exactly what we had thought it would be. And I'm pretty sure the over 600 participants that are there, both in our website and the YouTube channel, there's almost 700 plus, are really happy with the talk. So we will again come back to you with the history. So now the next talk is on investigations in vertigo. So just a moment. Yeah, so this talk will be delivered by just a minute. By Dr. Pratik Parwal, and so just a brief CV. Dr. Pratik Parwal, he is currently in the position of a vertigo specialist in Cyclops Meditech Private Limited, Bangalore. He has previously been with Anirban sir in Kolkata. Before that, he was a senior resident in UMS Medical College, Saifi, Uttar Pradesh. Junior resident in ENT Tata Main Hospital, Jamshedpur. He did his MBBS in 2006 to 2012 and his DNB in ENT in 2014 to 17. He has numerous publications and awards. Special training has been in vertigo and balance disorder under Dr. Srinivas Dorasala at Cyclops Meditech, and also under Dr. Anirban Viswas at Kolkata, West Bengal. He has been a guest lecturer at a number of events. With this, I now hand over the podium to Dr. Pradeep.
There is a small correction. He is training me. He is training me. I am not training him.
Okay.
So thank you so much for the invitation, sir.
My pleasure, boss.
Yes, sir. So I was supposed to give the talk after the history part, but so I will take up from there only.
Yes.
And my deepest regards to Dr. Hitesh Shah and his family. Bhagwan unki atma ko shanti de and parivar ko bal de. So I will be starting with examination and investigation. So after the history part, so I will be taking forward from the history part. So in the history, actually we have so many doubts. For example, we are asking whether it is a true spinning vertigo, or you feel that you inside yourself inside are you are only spinning. So we have to make a distinction whether it is a true spinning vertigo, or is it that you are feeling that there is a vertigo. Second question is, whenever we ask the patient that do you feel that when you are walking all the signboards are moving up and down, up and down? So in that also sometimes the patient is not able to explain himself, or we are not able to explain the word oscillopsia. So there are some confusion most of the times. Similar is for syncope also. and for tilt. So what we can do is we can show some videos to the patient and ask. So this is the first video, and we can ask the patient whether you feel like this or not. So if a patient is having actual spinning vertigo, all the environment, all the things which he sees will be moving in a particular direction. So if a patient says, yes, sir, this is exactly what I feel, then we can be sure that it is a true spinning vertigo. Similarly, for oscillopsia, we can ask the patient whether he feels like this, that everything is moving up and down, up and down, up and down. And if the patient says, yes, this is exactly what I feel, then we can be sure that it is oscillopsia. Similarly, for syncope, we ask the patient whether you had any history of loss of consciousness or there are some blackouts or not. So there also patient sometimes does not give us the correct answer. So we can show this video and ask whether he feels like this, that there is a gradual dimming of the vision, and then he can wake. So similarly, so eventually the light will go, everything will be dim, and he may or may not lose the consciousness. Similarly, for the tilt, whenever we ask the patient that you are feeling that, do you feel that everything is tilted in a particular direction? Sometimes he might say that he is confused. So we can show this video. So this is the actual tilt in a vestibular patient, in a peripheral vestibular disorder patient. So now coming to the point where we are sitting in front of the patient, and then we have to examine few things. First and foremost thing is pallor. We have to understand that anemia is the most common disorder in Indian females, and anemia can cause, or any nutritional deficiency can be a cause of vertigo. And in these patients, generally all the examinations, all the vestibular examinations are normal. So we have to make sure that we see pallor, we see the build of the patient, we see the facial expression, so that we can make out whether the patient is having any facial palsy, or whether the patient is in so much pain. We have to see the head tilt also. Sometimes it is associated with the ocular tilt reaction. Sometimes it is associated with uh, extraocular muscle palsies. So we have to note that whether there is a head tilt or not. We have to see the voice of the patient, whether it is very shrilling voice, whether it is very bulky voice, husky voice, or whether he is very conscious or very anxious, or he's very sad that doctor, I am suffering uh, suffering from this vertigo since 3 years and I am hopeless. So we have to monitor all these things also. And cognition is very important point, as told by Dr. Anirban sir also. To check cognition, we can just ask the patient that what is the date today, where are you, and you can ask to do some multiplications like 4 5s are 7 7s are, and you can check the level of cognition. It is mainly impaired in elderly patients or some in congenital patients also. We have to see the way of talking also, so we can notice some dysarthria in those patients. So first one is we have to see the face. Then we have to see the pallor. It is the most simple thing. We just ask the patient hand. We can see the hand and we can compare it with ours. And then we have to see the head tilt and the eyes. So I have to just move it a little up. Yeah. So we can actually see that whether there is a third nerve palsy, a fourth nerve palsy, or a sixth nerve palsy. Excuse me. Then we have to move forward to the movement part. We have to see, are there any tremors of the hand, tremors of the lips, tremors of the face. Is there any twitching of the face? How the patient is smiling, whether there is a deviation of face. And then we have to see the eye movements. So sometimes we can see that the patient is having a spontaneous nystagmus, or there might be a congenital nystagmus, or there might be a acquired pendular nystagmus. So then we have to note it. We have to also note that is there any diplopia, or there is misalignment between the two eyeballs. So I am going to show you a video. Just let me optimize it. So this is a patient which came to us for a ear pain. And we can see that she is having a congenital nystagmus. So make sure that we don't miss these kinds of patients. So this is another patient in which we have to see the tremors. So we normally ask the patient to hold his hands in the front, and we can see the tremors. And we can also ask the patient to do some finger to nose test so that we can confirm that it is really a tremor. And then we can think in the terms of demyelinating disease or Parkinson disease. Then the most important part is gait examination. The first one to do is a Romberg's examination, Romberg's test. And then we have to do a sharpened Romberg, in which we ask the patient to fold their hands to the chest and then stand erect. To make it little bit harder, we can also ask the patient to do this Romberg's test on foam. So this will be a very difficult situation for the patient, as we have removed the proprioception from the legs. To make it more difficult, we can also ask the patient to lift their chin up so that we also remove the vestibular inputs. Then we should be doing tandem gait test, then the Unterberger test, and then the get up and go test. So in get up and go test, we ask the patient, 1 minute, hello, hello, yes, just a minute. Yeah, sorry, I got a call. So I would like to, this video I have taken from YouTube. It is from by Bay State Health. So that was a credit for the video. So coming to the gait test, we ask the patient to sit on a particular chair, then stand up without holding anything, walk for 3 meters, and then come back. So we have to see two things: whether he is able to get up from the chair easily or not, and what time he is taking, and then how he is making it turn, whether he is able to do it independently or not. And we have to monitor the timing. Second important test is Unterberger test, in which we ask the patient to do a stepping on a fixed position, and then we see the deviation, whether it is to the right side or to the left side. A deviation of more than 30 degrees is generally considered as pathological, and it helps us uh, pointing towards the side of the lesion or the side of the vestibular loss. So it's a very easy test to do, and we can get more info on this. And one more thing to note is, if any of these tests are impaired, or the patient is not able to do correctly, or he is very anxious, you can just divert his attention from the disease itself or the testing itself, and you can ask the patient to do some mental calculations, like you just tell me the table of 9, or you can just add 5 plus 7 plus 7 plus 7, so that the concentration of the patient is now on the mathematics or the arithmetic part, and then we can actually get the proper results from this patient. Then we have to check the reflexes. It is very good thing to do. So first of all, we have to check knee jerk, then ankle jerk, then vibration test, which can be done by using a 256 hertz tuning fork or a 126 hertz tuning fork. And we have to compare it unilaterally, upper limb and the lower limb. We can diagnose peripheral neuropathy or uh, diabetic neuropathy, or large tract neuropathy from this test. We have to also do the touch test. So for touch test, what we can do, we can just take the backside of the tuning fork and we can ask the patient to just tell us whether he is able to feel the touch, or else we can use a cotton. We roll a cotton very finely and then we touch the face and the upper limb and the lower limb, and we have to compare it. Similarly, we have to do the temperature test. So temperature test, generally we do it right to left, and meanwhile we can also do the corneal test for the fifth nerve, which is for the acoustic neuroma. And meanwhile, when we are doing the ankle jerk, we can also see the pedal edema. So by taking this approach, we are actually ruling out majority of metabolic or systemic disorders. So by this, we are actually very sure that it is not a systemic disorder which is causing the vertigo. And now we can proceed to a specialized uh, examination for vertigo. So this is how we can do the touch test, temperature test, and the knee jerks. So the main idea is we should not miss this kind of patient. We should not go directly to the vestibular test without looking at the patient, without seeing the patient, without talking to the patient. That's the main motto of this presentation. So next, we are coming to the specialized vertigo testing. The first thing is to do a blood pressure in lying down position and then in standing position. So by checking the blood pressure along with the heart rate, we can actually diagnose that is this patient is of orthostatic hypotension or not. If the diastolic is decreasing by 10 and the systolic is decreasing by 20, then we can be sure that, okay, it could be orthostatic hypotension. And if the history is very specific, then we can be pretty sure that it could be just a orthostatic hypotension. If it is associated with increase of heart rate by more than 30 beats per minute, then we can say that it is a postural orthostatic tachycardia syndrome, that is POTS. So we have to check the pulse while we are testing the blood pressure. We can also do some blood investigation if required, like if family is vegetarian and we are suspecting that vibration sense is not adequate on the upper limb and the lower limb, then we can suspect that it might be due to vitamin B12 deficiency, or there could be, or the patient might be a alcoholic, and we can suspect that, there might be a thiamine deficiency or B complex deficiency. Or if the vertigo is recurrent or the BPPV is recurrent, and we can suspect that, okay, this might be due to calcium deficiency. So in certain situations, we can go for blood investigations. In blood investigations, we can also do some autoimmune antibody test if we are seeing that a patient is also a hypothyroidism, and there are also manifestation of other autoimmune disorders, like the patient is having um, discoloration of the skin, the patches are there, and he's also having some kidney disorders of pheochromocytoma, etc. In that case, we have to do the complete autoimmune testing also. And if you're suspecting that patient is not able to view correctly, or there is a chance of intracranial hypertension, or there is some vision deformity, or if you see that the patient is not able to express the symptoms correctly, if you feel that if fundoscopy is needed, then just go for it. In our clinic, we generally do fundoscopy for all the patients. In fundus, we look for mainly two or three things. First one is if there is a nystagmus, which is only on the fundus examination and not present naked to the eye. Second thing is we look for papilloedema or pseudopapilloedema. Third thing is we generally see the position of macula in both the eyes, whether they are horizontal or they are at an angle. So these are the main things which we see in the fundoscopy. Now coming to visual acuity and eye movements. Ideally, we should have a Snellen charts in our clinic, and we should do visual acuity by ourselves. There are other variants of visual acuity also for testing the VOR with the visual acuity, that is known as dynamic visual acuity, in which we ask the patient to look at the Snell charts, and we rotate the patient head left to right with a little bit high frequency. And we ask the patient whether see he can see the last line or the first line, or how many lines he can see. A decrease of more than 3 lines can be considered as a VOR impairment. And then we have to also monitor the eye movements. We have to check the eye movements to rule out any strabismus or any extraocular palsy or any uh, artifacts in our PNG examination. So for that, it is very easy to do. First, we can ask the patient to look in a cross way, like in a X way. So we ask the patient to look right, then left side down. Then we can ask the patient to look opposite side and then down side. And after that, we have to make a H. H means then we have to go for from right up to right down, then to the center. Then from the center, we have to move to the left side, left up and left down. By doing this, we can actually test all the extraocular muscles and we can see if there is any latent strabismus or a obvious strabismus. Then the most uh, easy test to do is cover uncover test. So in cover uncover test, we cover the patient's eye and then we wait for a few seconds and then we uncover it. And if there is some pathology, then we can see that the eyes are going up. So if you see that there is a vertical misalignment of one eye or the other eye, then we can say that there is a skew deviation. Actually, there are three tests which can be done with the cover. First one is cover test, second one is cover uncover test, and then there is an alternate cover test. By doing this, actually we can diagnose any latent strabismus or diplopia or any extraocular muscle palsy. We can see the deviations if they are present. Actually, the deviations of the eye grow if we wait for few seconds. And we should look for two kinds of deviation. First one is the primary deviation, that is in the paretic eye or uh, or the eye which has palsy. And we have to see the secondary deviation also, which is seen in the normal eye. And then if we see that there is some head tilt also, or there is some misalignment, then we have to make sure that we are excluding extraocular muscle palsy, that the most commonly is superior oblique palsy. To make sure, we can do 4 steps. The steps are very easy. First is we have to identify which eye is up or in which eye there is hypertrophy. Then we have to ask the patient to look at right gaze and then left gaze. Then we ask the patient to look up and down. And then we can do the Belchowski head tilt test, in which we actually tilts the patient head to right side in the roll plane and then to the left side. And we can see whether whether the hypertrophy is getting more or less. So these are the examination for extraocular muscles, which we should do in every case. Now coming to specific test for inner ear. So the most common test which we do is pure tone audiometry. If you don't have pure tone audiometry, you can also do tuning fork test. But pure tone audiometry is highly useful for Meniere's disease patient, and it should be done in every patient which you see, whether it is tinnitus or not, whether the patient is telling that I am having hearing loss since 2 days or 7 months, or whether he is perfectly all right also. You have to do a pure tone audiometry test. Now, other test which we can do is impedance test if it is required, if the history is very specific, or we can do a autoacoustic emission if it is required. Am I audible or my voice is low?
No,
Your voice is clear. Your voice is clear.
very clear.
Very clear.
Okay, sir. So then after doing the pure tone audiometry, we have to do some highly specific test. It is not supposed to be done on every patient. It is to be done only for few patients, few category of patients. For example, you are working in a hospital and you got an emergency, and a patient came to you with acute vestibular syndrome, Acute vestibular syndrome means the patient is not able to stand up, he is not able to talk, and he is just lying down in bed on one side, taking one side turn, and on examining the patient, you saw that there is a nystagmus. And immediately you think, oh my God, what should I do now? So the main thing which you have to do is you have to make sure that this is a peripheral disorder or this is a stroke, because both of them can present in the similar way. So if it is a stroke, then you have to work very hard, and then you have to do the complete assessment of the patient. If it is peripheral vestibular disorder or like vestibular neuritis, then you can be sure that okay, so nobody is going to die. So in that situation, what you have to do is you have to do hints test. So what do you mean by hints? Hints is head impulse. HI is hints, head impulse. N stands for nystagmus. TS stands for test of skew. So by definition, it is hints. And if we are also including the findings, then it is known as hints to infarct. So I have not gone into detail, but hints to infarct means IN means there is a impairment of the uh, head impulse test. FA means there is fluctuation of the. Uh, okay, so I think I'm not very sure what is it. So basically, head impulse should be negative, or head impulse should be normal in patients of central disorder patient,
Dr.
and the
Pratik,
nystagmus should not be gazing.
Dr. Pratik,
Yes, sir.
Dr. Pratik. Okay, I think FA is fast phase alternating.
Ha, yes, sir. FA is fast phase alternating, and then RCT is test of there is misalignment of the eye in the vertical direction, that is known as test of skew. So in total, if the patient is having a stroke, then the head impulse would be normal. Nystagmus will be alternating. So if we ask the patient to look on the left side, then the nystagmus will be left beating. If we ask the patient to look on the right side, the nystagmus will be right beating. We can also term it as gaze-induced nystagmus. And we can also do cover uncover test so that we can test the skew deviation or vertical misalignment of the eye. So in stroke patient, this is the finding, but if the patient is having vestibular neuritis, the findings are very simple. Head impulse will be impaired to the side of the lesion. So if the patient is having right-sided vestibular neuritis, so when you move the patient's head to the right side, there will be a corrective saccade. Similarly, the nystagmus will be constant throughout. There might be little decrease in the intensity of the nystagmus when the patient is looking away from the fast phase. That is due to Alexander's adaptation, and skew deviation will be negative. There will be no misalignment of the eyes if the patient is having vestibular neuritis. The other thing is hints plus examination. So hints plus means PTA. So if we also did a Puritan audiometry on the patient, then we can say that we did hints plus. Similarly, with hints plus, we should actually make the patient stand up. If the patient is able to stand up even for 2 seconds without support, then we can say that, okay, so this is safe. So we can say that this is not stroke, then we can move forward. But we have to make sure that to be very, very sure, we can also see some other features of stroke in doing high frequency head shake in the horizontal direction. So what we can see is we can see a early and prompt reversal of nystagmus if we are doing a high frequency head shake in the horizontal direction. So what does it mean? I will show you the graph also. So if after doing a high frequency head shake, we got a right and down beating nystagmus, exactly it should be right beating nystagmus or left beating. Then if it is reversing very soon or it is decaying very soon, then we can suspect a central disorder or a stroke. We have to see the perverted nystagmus. So what do you mean by perverted nystagmus? Any nystagmus which is not in the plane of stimulation can be termed as a perverted nystagmus in neurology. So mostly it is used for high frequency head shake, which is done in horizontal plane. So if we are shaking the patient's head in horizontal direction, that is from left to right, and if we got a nystagmus which is upbeating or downbeating, then we can say that this is a perverted nystagmus, and we should suspect a cerebellar dysfunction or a posterior circulation stroke. Similarly, if we got a nystagmus which is opposite to the spontaneous nystagmus, so if it is a vestibular neuritis case, then we should suspect a right beating or left beating nystagmus. But after doing high frequency head shake, if we got the opposite side nystagmus or a vertical nystagmus, then we can suspect that this is not a peripheral disorder, and we should suspect a stroke. And then we should alarm everybody, and we should call for help. So I would like to show you case induced nystagmus. So I will just optimize it. So just let me know if you are able to see, or should I optimize it again? So the patient is looking to the left side, and we can see that there is a nystagmus. Is it apparent? Now, now this is, okay, this one is different. Now in this, the patient is looking to the right side, and we can see that this is a right beating nystagmus.
Audio freedom powering on.
So this is a very simple test. We can just ask the patient to look at the finger, and if we see that on right gaze he is having a right beating nystagmus, on left gaze he is having a left beat nystagmus, then you can confidently call cardiologist or neurologist and then hand over the patient. Now coming to some special tests. So I will be talking on video nystagmography. So the first test which we do or we should do is Saccard. So I will not be showing you the normal pattern, but I will be showing you the disease pattern or disorders, the pattern in the disorders. So in the first graph, we can see that there is a hypometria, or this is a staircase phenomenon. So this is generally seen in patients with cerebellar atrophy or age-related atrophy also. Uh, the thing to notice is in exactly in this saccade, the patient's eyes are moving to the right side, and then they are staying there, and then they are coming back. So we can see that this hypometria is only on the one side. So when the patient is looking to the right side, then there is some instability or there is some hypometria. But on coming back, there is no hypometria. So we can suspect that there might be a unilateral lesion. So in general, impaired saccade or impaired pursuit is like, okay, so we have to do something. But if the impairment is half means it's only on the left side or only on the right side, then we have to be more careful, because it could be a demyelinating disease, or it could be a early Parkinson disease, or it could be a early space occupying lesion. So then if we intervene early, we can save the patient. Similarly, in the second graph, we can see that there is no stability in the patient's eye. Either he's looking to the right side, or when he is looking on the center gaze or the left gaze. So this is a patient of congenital pendular nystagmus. So we have to notice these patterns also. Similarly, in this first graph, in the above graph, we can see that there are some hypometrias, but the gaze is not stable in the left side also. In the second graph, we can see that the gaze to the right side, actually this is a upward saccade, upward movement. So patient is looking up and then down. So when the patient is looking up, the eyes are not going in a straight fashion. So this is known as slow saccade. So they are drifting actually after a point of time. So this is also seen in some cases of cerebellar dystrophy. So this, okay, so this is not working. So I would like to show you the video of this patient. 1 minute. Just give me a minute. Sorry for the delay. So this patient is making a saccade in left side and right side. So what is happening is that there is something which is pulling the eye to the center. You can appreciate it. So the eyes are not stable either on the right gaze or on the left gaze. So this also we have to see. Now coming to the smooth pursuit part. In the first graph, we can see that the smooth pursuit is impaired. So ideally, it should be very smooth line. It should be just like the green line, which we can see here in the first graph. In the second also, we can see that it is a completely broken pursuit and the patient's head and the patient's eyes are not moving in a proper fashion. But in the third graph, this is actually more dangerous because we can see whenever the patient is moving the eyes to the down gaze or the downward movement he's doing, there are some infiltrations or saccade or there is inability to do. So we can suspect that this could be a unilateral disorder and we have to be very careful with this patient. Now coming to high frequency head shake test. So I have already told about the perverted nystagmus in hints examination part. So in this test, what we are doing is we are actually doing a high frequency head shake in the horizontal plane. For 10 seconds, we rotate the patient head left, right, and then we can see the nystagmus. So in above line, you can see that the nystagmus is in the up direction or it is a upbeating nystagmus. It is known as perverted nystagmus and it is a sign of central disorder and we have to directly call the neurologist and show him there. So this first is the perverted nystagmus which is in the opposite plane to which we are stimulating. In the second graph, in the below graph, we can see that there is a right beating nystagmus which after few seconds changed to the opposite side and it became left beating nystagmus. So this is known as biphasic nystagmus. This is this is also a pathognomic of central disorder, but in some cases of vestibular neuritis in which compensation is happening or it is inadequate compensation, then also we can see this kind of nystagmus. But most commonly we see it on the central disorders patient. Now coming to hyperventilation. So the method to do hyperventilation test is we explain the patient that we are going to ask you to take deep breaths and then you have to do it for 60 seconds and then you have to breathe normally. So we record, initially we record for 20 seconds so that we can see the spontaneous nystagmus. Then for 60 seconds, we hyperventilate the patient and then we see is there any change of nystagmus for 50 to 70 seconds. So in the first graph, we can see that there is a right beating nystagmus which got suppressed after few seconds of hyperventilation and eventually it turned into a left beating nystagmus. So this is also known as biphasic nystagmus on hyperventilation and this can show us that there might be a cross compression or there might be any acoustic neuroma or there might be any damage or regeneration to the nerves, especially the eighth cranial nerve. In the third part, in the second graph, what we can see is there is a right beating nystagmus which changed to left beating nystagmus, which again converted to right beating nystagmus. So this is known as triphasic nystagmus. So the earlier one is biphasic and this one is triphasic nystagmus. So this is also not good. We have to dig harder. We have, and the main thing is if we see these kinds of nystagmus on say hyperventilation test, then we have to actually go back to Saccards, go back to optokinetic test, go back to smooth pursuit, and we have to see all the findings, and then we have to make the letter out of it. So hyperventilation test is a letter. Then we have to make a word or a sentence so that we will be very clear. Okay, so hyperventilation shows this. Smooth pursuit is impaired. High frequency head shake is normal. Subjective visual vertical is impaired. Head impulse is impaired. So then we should actually analyze all the tests, and then we can get it that yes, history is also specific to this, examination is also specific to this, and then I can declare that this patient needs a neurological opinion or he needs a MRI evaluation. So coming to head impulse test, I will not be going very deep into the head impulse test. It is a very easy test to do. It's a bedside evaluation of vestibulo-ocular reflex or the intactness of your vestibular system. Uh, it, the main role is in acute vestibular syndrome. If it is peripheral or vestibular neuritis, then we can see that head impulse is impaired. What does it mean is when the patient's head is moved to the right side and the patient is having a right-sided vestibular neuritis, then there will be some corrective saccades. So this is seen in vestibular neuritis. Note, it is normal in the central disorders or stroke patient. It is normal. Head impulse test is normal. We can also see this head impulse test impaired in few cases of Meniere's disease, not in the early stage, but in late stage. And we commonly see this in bilateral vestibulopathy patients, and the gain is reduced. And in few cases of cerebellar disorders, we can also see head impulse, which is impaired. Especially in cerebellar disorders, we can see that if we are doing a horizontal head impulse test, we get a perverted nystagmus. So I have a video, I will show you that also. So the head impulse test can be done in the horizontal plane to test both horizontal canals, right and left. It can also be done for anterior canals and for the posterior canals also. So to test right anterior canal, we have to move the patient's head by 30 to 40 degree to the left side so that the right anterior canal is in the straight in particular alignment, and then we shake the patient's head anteriorly and posteriorly. Anteriorly to test the anterior canal, posteriorly to test the left posterior canal. That is in RALP and LARP plane. So this is the usual graph which we get in our balance size software, and in the second graph we can see that there is a double peaking. So what do you mean by double peaking? So in head impulse test, you get two kinds of saccades. One is covert saccade and other one is overt saccade. So I'm not going to explain in detail, but just remember one thing. Initially, they will be overt saccade, but after a period of time, after the compensation which was given by brain, these overt saccades are converted to covert saccade. Okay, so if we see covert saccade, then it is a sign of vestibular compensation by central nervous system. Yeah, this is a, let me optimize for video. So we are testing the head impulse test, and you can see that there is little bit shakiness when the patient's head is moved to the right side, but not on the left side. So I will start from the beginning. Now he is looking straight. Now we are doing head impulse on the right side, and you can see that there is some shakiness. And now we are testing the left side. Now there is no shake. So this means that this patient's right side vestibular system is hypoactive. Yeah, perverted nystagmus in high frequency head shake. Just give me 1 minute. So can you see the video? Oh no, this is high frequency head shake. So this is high frequency head shake actually, and you can see a downbeat nystagmus, which is also a type of perverted nystagmus. So ideally, we should get a right beating or down beating, right beating or left beating nystagmus. But in this patient, we are getting a down beating nystagmus, so which is a perverted nystagmus. So sorry. Yes. So we are doing a left-sided head impulse test, and if you see clearly that there is down beating nystagmus. Srinivas sir, is it visible, sir?
Yeah, it is visible. It is visible.
Okay. So we can see that there is downbeat nystagmus. So gaze in, okay. Now coming to WEMP, I will be cut shorting this. The main purpose of WEMP, or we, in majority of cases, we do just cervical WEMP. And the purpose of CWEMP is to determine the integrity and the health of saccule, which is one part of the otolith system. And it also help us to understand whether the inferior vestibular nerve and the other connections are intact and are working normally or not. So I would just go through superior semicircular canal dehiscence. In superior semicircular canal dehiscence, we can see that the responses are observed on a less decibel, less intensity of sound. So normally we give 90 or 95 decibels to the patient at 500 hertz, and we see a normal graph in a normal person. We can see the peaks P1 and N1, but in patients with superior semicircular canal dehiscence, we can get this peaks even on lesser intensity of sound or lesser decibels also. So in this patient, we can see that on 75 decibels, we can see the peak, the formation of peak, and even we can see slight peaks on 70 decibels. While on the same patient on the left side on 75 decibel, there is no peak, no peaks we can see, and on 95 decibels, we can again see the peaks. So we can say that this patient might be having a right-sided superior semicircular canal dehiscence. Similarly, for Meniere's disease, in normal patients at 500 hertz, we should get some peaks, but in Meniere's disease, there is some frequency tuning, and on 1000 hertz, we are getting the peaks. So in the right side, we can see that on giving 500 hertz, the formation of peaks is not good. But when we are giving 1000 hertz to the right side, we can see the formation of peaks. While on the left side, the peaks are formed on left 500 hertz also and on 1000 hertz also. So this is a feature of Meniere's disease. Now, other tests which I have not included because I thought that we have limited time and I would cross over the time. So caloric test, I have not included. Caloric test is mainly useful nowadays in Meniere's disease patient. And after vestibular neurectomy, we can actually derive something. We can see the cross connections and all. And posturography is also one of the tests. ECOG is also very famous test which we can do. All the tests which I have mentioned or all the examination which I have mentioned are not to be done in every patient. So we have to categorize from the history only, that, okay, so this patient is telling that if the patient is saying three things, the nystag, I am having spinning vertigo for less than a minute. It is mainly on lying down position, and I am okay, perfectly okay during the day. So we can suspect that, okay, it might be a positional nystagmus. Then you should not do the WEMP test or the PTA. Then you can skip those tests, and you can directly go to the positional test, and you can do Dix-Solpike maculopagnani or supine head hanging to see the positional nature of the nystagmus. And then you can correct the otoliths which are outside the utricle into the semicircular canal. So by this, I end my topic, and thank you so much for listening to me. And thank you, Surajit sir, for inviting me. Thank you, Srinivas sir. So I hand over to Dr. Surajit sir. Hello.
Hello.
Dr. Pratik?
Yeah.
Yes, sir.
So yeah, Srinivas sir.
Yes, sir.
Yes, I think Pratik has given a very beautiful presentation, and we'll not take much time. We'll straight away go to your next topic, that is history taking. I know I have heard this. It's a very beautiful history taking lectures that you give, sir. So over to you, sir, straight.
Yeah. So I'm in the interest of time, what I made it a very another short presentation, okay, on history. Okay, I'm not going into full detail, but based on two papers, okay, that is a different kind of history. So okay, fine. So when it comes to history taking, in the interest of time, I'm making a very brief presentation. It's not going to go in the normal history fashion, but the important points are going to be covered. So when it comes to history taking, there are two papers that are very, very important. One is Floris White's, okay, he's a very, very accomplished vestibular practitioner from Antwerp University. I had the opportunity of meeting him along with Anirban sir in Moscow. Okay, so this is his paper. Okay, So Stoned. It is called So Stoned. So Stoned is a mnemonic. I'll expand all the things as it comes down. And then the other thing is Dr. Thomas Brand, Michael Stroop, and Marianne Dietrich. Okay, their paper. Okay, I have had the good fortune of meeting all the three in person. Okay, Dr. Thomas Brand especially is with all his accomplishments, is a very, very humble person. Okay, so they have written these 5 keys for diagnosing most vertigo, dizziness in imbalance syndromes and expert opinion. Okay, so these two things. So basically, what is this 5 keys approach? Is this the 5 keys approach is simple. When the person comes, based on the history, it is not about, okay, you ask so many things about I'm not sure whether you are able to see. Okay. Have I switched on my video? Yeah.
So we are seeing your presentation, sir. We're seeing your
Yes, sir. We are seeing.
Fine. I don't know what is happening. Fine. Okay. So something happened. Okay. As long as you're seeing the presentation, it is fine. So what it says is that the paroxysmal, there are 5, you talk to patient for 5 minutes, within 5 minutes, you'll be able to place, like you ask them what is the kind of vertigo, how long it lasts, what brings it about, all these things we ask. So these are routine questions that we ask. You first ask, what are you facing? And he tells that I'm facing either dizziness or vertigo. And then you ask whether it is triggered, how long it lasts. These are the common things. Once you have done that, you place them in one of these group. Okay, that particular patient, place them in one of these groups. The groups that this position paper suggests is a very beautiful thing. I don't know why I'm not able to go back. This is one problem with Zoom. Okay. Yeah, fine. Okay. So you put the patient in benign paroxysmal positional vertigo. The moment you put the patient in a paroxysmal positional vertigo means it is coming in paroxysms lasting a few seconds, and then it is coming and going, and there is a trigger, that is position is the trigger. Then you think in terms of not many things, benign paroxysmal positional vertigo. If it is not that, then think in terms of central positional vertigo or central positional nystagmus. Okay, whatever. Then comes spontaneous attacks. Spontaneous means there is no trigger, it just comes off. Okay, there is no immediately known trigger. There could have been a trigger yesterday or maybe a few hours ago, but it is not something like benign paroxysmal where the trigger is, it happens there and immediately sets off. It is not like that. It happened like he has been hungry, he's feeling hungry, or he's missed sleep, or he's been tensed. That kind of a trigger could be there, but generally it is considered spontaneous. So spontaneous but recurrent attacks of vertigo. Then there are not many differential diagnoses in that group. One is vestibular migraine and Meniere's disease. Then the person comes with the first attack of a sustained rotational vertigo. He comes at that time, and then it is going on and on and on till the time you see, and this is the first time. Okay, in which case, of course, it is possible that it is the first attack of vertiginous migraine. It is possible that it is the first attack of Meniere's disease, but then that comes later. Okay, they need a few episodes of repetition to put that diagnosis. But when they come for the first time, it is always safer to think in terms of either a vestibular neuritis after having ruled out a central cause, that is a central pseudoneuritis. Okay, so after having ruled out a central cause, then it becomes a vestibular neuritis, and Pratik had beautifully presented how to rule out a central cause. That is the Hints plus, that is with audiology, then Hints plus standing, then Hints plus standing plus head shaking. So everything was covered. You employ all those things and you will never miss a central condition. Then comes the frequent spells of dizziness or imbalance. Means it keeps coming again and again and again and again and again and again. Probably it is related to vestibular paroxysmia or superior semicircular canal. Not semicircular canal. You should more correctly call it a superior canal dehiscence syndrome. Okay, superior canal dehiscence syndrome is what you're supposed to be calling it. So that is vestibular and the other possibility. Just like when you've seen patients with hemifacial spasms, you've seen patients with trigeminal neuralgia. So you know how they present. They keep presenting with frequent spells coming again and again. So its vestibular analog is nothing but vestibular paroxysmia. So they come as frequent spells. How do you differentiate? How do you more specifically diagnose vestibular paroxysmia? Of course, we can do a MRI with CIS-3D and demonstrate the presence of a cross compression and all those things. But the way in which the best way or the gold standard of diagnosing vestibular paroxysmia is response to carbimazepine. So the response to carbimazepine is the way in which you are going to diagnose vestibular paroxysmia. Okay, there are cases in which we could not demonstrate a cross compression, still they respond and we take it as that. And there are other places where there are huge cross compression, they are asymptomatic. So response to carbimazepine is what is going to be the diagnosis. Then postural imbalance without other neurological symptoms, only postural imbalance. Then what these authors, the three people, Thomas Brandt, Michael Stroop and Marianne Dietrich recommend is you consider these two things, phobic postural vertigo or bilateral vestibulopathy. The reason for giving these 5 different groups, okay, based on a history. See, all these points is based on talking to the patient for just 5 minutes. Or he tells that since yesterday, when I roll in bed, I'm getting, it goes into the first group. Okay, he tells like last 2 years, I'm getting again and again, whenever I get, it comes for 20 minutes or 2 hours. And then at that time, I'm very tired. After that, I become better. It goes to the second group. Somebody comes and tells, this is the first time I've never had this. This is the first time 1 hour ago, 2 hours ago, or since yesterday, I'm going through this, comes into the third group. Everything is based on history only. But then based on the history, so the history should be thought about to put into one of these groups. Then you know what questions to ask, so that you are thinking from the beginning only which group it belongs. Then somebody tells frequent spells of the again and again, but very short lasting, but keeps coming again and again. Then you think in terms of the fourth group. Then some person tells, do you have vertigo? He tells, no, I don't have vertigo. Do it go round and round? No. Then he tells, when you're sleeping in bed, any problem? No. Then once I stand up and I start walking is the problem. Then you think in terms of the fifth group. So it is like that. This is all history only, but a history in a totally different direction. This history is a history which goes in the direction of straight away going to one of the group and trying to find out the cause. Okay. So that is it. Then the other beautiful paper that has come out is the so-stoned paper. Depending on how much time is there, I will go through this. Then if there is time, I will give my own approach. Okay. So the so-stoned approach is, okay, this is called a common sense approach for the dizzy patient. Okay, this comes from Floris White's. Okay. So what is this approach? Okay, yes, okay, in the so-stone, first S stands for symptoms. Then second stands for often, how often it is. So what are the basic symptoms? Okay, is it vertigo or spinning? Okay, in which, and it goes into a certain category. Okay, okay. So if it is vertigo, real going round and round and round, then you think more in terms of neuritis, BPPV, canal dehiscence, Meniere's disease, like that. Okay, if it is basically postural instability, the main symptom, then you think in terms of bilateral vestibulopathy. So you see the correlation between the other paper, which is 5, and here. So there is a correlation. Okay, in the sense, everybody, all authors are thinking in the same direction. If it is basically postural instability, think in terms of bilateral vestibulopathy. If it is not bilateral vestibulopathy, then you think in terms of either a peripheral neuropathy, that is the proprioceptive loss, or other central causes like cerebellar ataxia. So like that, if somebody is going through lightheadedness, dizziness, then you think more in terms of psychological disorders or persistent postural perceptual dizziness, something like that. Okay. Okay. So then there are the otolith dysfunction, which will be presenting as either a linear sensations of push or tilt of the perceived vertical, which was shown in previous presentation by Dr. Pratik. Okay. And then of course we also have drop attacks. Okay, which again can be one of the early manifestations of the late stage of Meniere's disease, like that. So you can ask the symptoms. So we should know all the symptoms. Generally, we've been only asking whether there is true rotatory or no. So, but then it is not just about that. We should be asking the different kinds of symptoms. One is whether there is vertigo, whether there is any postural instability, okay, whether there is any lightheadedness, okay, and whether there is any perception of the tilt. Visual world, if there is a tilt of the visual world, when it comes, it is short lasting. Then whether there have been falls or drop attacks, or whether there is any latropulsion, okay, even oscillopsia. These kind of the symptoms are going to be asked. Then comes, once you know the symptoms, how often do they occur is very, very important. There again in the previous talk, previous paper, if you see, if it is single episode, it goes into one category. If it is multiple episodes, it goes into another category, like that. So a single attack of acute vertigo is the hallmark of acute peripheral vestibulopathy. Also, it can happen in stroke. Okay. So attacks that occur almost daily are typical for BPPV. Okay. So, but also for vestibular migraine, perilymphatic fistula, superior canal dehiscence, all these things. Okay. And of course, vestibular paroxysmia. So how often things happen is also very, very important. And in that, there are three different kinds of temporal patterns. I'll just use a notation tool. So if there is a calendar of all the dates, so if there is a calendar of all 30 days in the calendar, okay. So first week, second week, third week, fourth week, whatever it is. So if the person is asked to mark in a calendar when they were there, so if they are marking 1 day, 2 day, 3 day, and then there are many symptom-free days, and again in the third week, 1, 2, 3. If it comes like this, and if it is still, if the person is having positional vertigo, and if it coming like this, so if he tells there is a positional triggered vertigo, and in the calendar it is coming like the 3 days, then you don't think in terms of BPPV, you think in terms of migrainous positional vertigo. But if the person tells since the time it started, it is coming every day, all days are being marked, till the time you treat, it is going on and on and on every day, then you think in terms of the mechanical positional vertigo, where there is a otolithic debris in the semicircular canal. Then if there is a person who tells he's been having, he comes to you, but here after you treat, in this condition you treat, then the person becomes better. After that he is symptom free, then it is mechanical BPPV. But the person comes, you do a positional maneuver, he may tell one day I'm better just because he saw our face and he is happy, so next day he is little better, but then after that it again starts. Okay, it has been going on and it continues in spite of your best maneuver. After all study, everything, it continues. Then you are probably suspecting a posterior cranial fossa lesion. If there is no posterior cranial fossa lesion, we have seen patients who were actually having a paraneoplastic cerebellar degeneration who present like this. So you do a search for malignancy throughout the body, something like that. So if MRI normal in the early stages, paraneoplastic cerebellar degeneration may not show anything in the MRI. So you may have to do this thing. So these are the different kinds of patterns, okay, where you can see. So you saw this a few days, goes off, then again few days, migraine. Continues till you treat, mechanical BPPV. It continues, you treat, still continues, think in terms of a central cause or some other cause which we are not able to diagnose. Okay. So that is how you approach this one. Okay. So this history has to be geared towards reaching a diagnosis, okay, rather than just geared towards accumulating data. Okay. So that is about this. Okay. Then since how long? Okay. This item focuses on how long the symptoms already exist. Additionally, what this tells. Okay, that is very important. Okay, one day versus for years, the connotations are very, very different. So take, for example, somebody who tells that all the time I am dizzy, and then he's going on and on to doctors for more than 5 years and he's all the time dizzy. Unlikely to be having anything very dangerous. Okay, you are not unlikely to miss anything in the intracranium. Okay, so that is one thing that we need to remember. Whereas another person who tells since yesterday, then you may have to be very careful. So like that, since when is very, very important. And what triggered, okay, what triggered, I underwent a spinal surgery, or I underwent I had a cesarean section. After that, okay, the problem started, or I had a uterus removed, and then after that the problem started, or after a immobilization, something. Since also means that one also. So after something it started, or so and so. That is important because the immobilization tells something else. Okay, strenuous physical activity, and afterwards it started. That indicates something else. So like that. So since when is also important. Then comes the trigger. This is the one thing. If you have a trigger, then it is going to give you the diagnosis. So if you have a trigger, it is going to give you the diagnosis. So like, what are the common triggers? If the person tells, okay, not rolling in bed, but lying down in bed straight. If I have a pillow, no problem. The moment I remove my pillow, I have a problem. Think in terms of Arnold Chiari, that kind of a manifestation. So rolling in bed, bending over down, looking up, then think in terms of benign paroxysmal positional vertigo. Turning the neck to one side, to the right or to the left is causing a problem. Think in terms of rotational vertebral artery syndrome. Okay. Then the person tells, only in one particular position I get the vertigo, but then otherwise I don't get the vertigo. And then you do all evaluation, everything is normal. Probably it is migraine. Okay, migraine also is known to cause one particular variety of dizziness where the person gets vertigo, even nystagmus, in a particular position of the head or body. Otherwise, they may not have anything else. Everything else turns out to be normal. So that is also there. It is written in the Neurology of Eye Movements by David Z. Okay, so that could be one of the possibilities. So like that, what is triggering is very, very important. Okay, if the person tells a loud sound is triggering, probably you are looking at a third labyrinthine window. So if you get a trigger, you almost have the diagnosis. Okay, like that. So that is very, very important. If you have a trigger, to get one trigger. So in the most of the history taking, the maximum time I spend is try to educate the patient about the actual triggers and teach them so that they can sometimes help, especially when it comes to the other diagnosis, like immediately apparent triggers, patient only will tell, but not so immediately apparent triggers, then we may have to help, like triggers for migraine and these things. Okay. Then otology. Okay, so the examination of the ear. We should never forget two things. Okay, that we may be vestibular practitioners. We may be calling ourselves neuro-otologists, whatever it is. But then we all came from MBBS. From MBBS, most of us are ENT. Okay, so we should remember that. Okay, that the disease does not know that you are a neuro-otologist. It can sometimes be that, not sometimes, it is so many times it's in that you think in terms of diagnosis like vestibular neuritis, or you may be thinking in terms of Meniere's disease also, but it may turn out that it's a clear-cut case of attic retraction pocket and a cholesteatoma. So otology should never be missed. Okay, we should never miss the otological examination. And the other thing in the otological examination, history taking, the otological history taking also, is that tinnitus. Okay, what is not commonly known is the commonest cause of pulsatile tinnitus The moment pulsatile tinnitus comes, when we were postgraduate students and all those things, we would be excited to look for something. Pulsatile tinnitus means, oh, maybe today I'm going to see my first case of, okay, glomus tympanicum or glomus jugulare or something. But the commonest cause of tinnitus is intracranial hypertension. So we have to look for idiopathic intracranial hypertension. And in that person, if you do an imaging, you can also specifically look or ask for any jugular bulb diverticulum. Okay. Primary problem could be idiopathic intracranial hypertension. Okay. Okay. Then, of course, neurology. We should never forget to take the to ask for neurological symptoms in the history taking. Okay, so this is how this so stoned is approaching this kind of a person with vertigo. Okay. Okay. Then how the also gives us especially with is that the rule is gradual improvement. Okay, it may progress over a few hours, but then after that, day 2 onwards, the rule is it has to be gradual improvement. If it is not gradual improvement, it is not vestibular neuritis. Okay, patient may feel devastated, that may be there, but actual symptoms, when you ask how is your actual vertigo compared to yesterday, today, it has to be better. Okay, and your examination findings also, if you are doing, it has to become better and better and better. So that is how a vestibular neuritis evolves. Whereas evolution for a Meniere's disease is totally different. It comes and goes, comes and attacks come, attacks go, attacks come, attacks go, something like that. Okay, in between, we have to keep in mind when it comes to the evolution. Okay. Then duration is very, 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 very important, because duration gives, in fact, there's a very beautiful slide by Dr. Avinash Pichlani. Maybe we can share that slide with everybody who has participated here, maybe tomorrow or day after tomorrow, where just based on the duration, you can place a particular diagnosis in different places, from seconds to hours to days. Just based on the duration, you can place them in different compartments. Okay, so BPPV is always seconds. Then one beautiful point that I have noticed from this thing in duration, if one particular person has all the 3 different durations, if all three types of duration is coming in the same patient, then you have to suspect, you have to think in terms of what? Migraine. Okay, if the same person gives all different kinds of durations in the same person, and if they are all real, that kind of different kind of durations, there are people who tell, when I'm taking a class, I feel like I'm being pushed to one side. That is momentary, not even a second. Then they tell that when I roll in bed, I get rotational vertigo lasting a few seconds. And then they tell, once I was having this vertigo for say half an hour, 1 hour, something like that. Then they tell, last 3 days I've been very bad, something like that. So all histories are there, different kinds of durations are there in the same person. That learning MBBS, if you know tuberculosis, you know medicine. So you can probably say that if you know migraine, you know neurotology. Okay. Okay. So these are like, in all these things, in the so stoned feature, he has placed different diagnoses and told how each of those things present, like in an acute vertigo, how a vestibular neuritis versus a stroke, how the different kind of features will be there. So like that, how to differentiate. Probably you can take a screenshot of these things at leisure, you can do, or otherwise this article is freely available. So that also you can take and read. So in the acute vertigo, and each of them, most of the time you will be right in making a diagnosis just by using this this one particular paper. It covers around 85% of the conditions. And the remaining 15% you can refer to your friend, okay, whom you don't like, so that. Okay. Then there is the chronic vertigo also. So persistent postural perceptual dizziness versus bilateral vestibulopathy. He is given. So we can come to a conclusion. One beautiful test which Dr. Pratik keeps doing for people who are like fiending or whatever it is, versus a person who is actually having a real postural imbalances. While doing a Romberg's test, a certain slight modification where he makes the patient's forearm to be stretched out, and on the forearm he asks the person to close the eyes, and then on the forearm he starts writing numbers and asks the patient to find out what number he is telling. So the patient's attention is drawn out and tries to tell, okay, you are now drawing 3, you are now drawing 1, or whatever it is. So during that particular time, what happens is the patient's posture, if it becomes stable, then you are probably dealing with the psychological condition. So something like this. Okay. So all these things are different things are placed. Okay. So, and then there is my approach. It takes about 1 hour. So I think as of now, I'll instead of going into my, because we are short of time, maybe this we can keep it for another session. Okay. Yeah. Dr. Surajit.
Thank you very much, sir. It was really nice. So, first of all, a big thank you to Srinivas sir for filling in. We suddenly went into a crisis when 2 of our speakers had to pull out at the last moment, and you have not let us feel their absence, at least as far as the academics goes. We always will feel their absence, both Dr. Hitesh and Dr. Paramita's absence, because every person brings with them a certain finance and certain, every dish needs all its ingredients, as they say. So we'll straight away revert back to you, since you are the moderator of the question answer session. So we can, I think, straight away go to the question answer round, sir. I'll request Dr. Pratik, and I hope Anirvan sir is also here to unmute. And we have a set of august guests with us in the studio, if I may say, virtual studio. We have Dr. Ramesh Rayuwal, we have Dr. Vijay Ghuge, we have Dr. Charuas Jagtap, we have Dr. Avinash Bislani, we have Dr. Anjana Sharma. All of them are here, apart from our speakers, that is Dr. Pratik Purwal and Srinivas sir. We have our mentor, Dr. Anirvan Biswas sir here, and we have the convener of our meeting, Dr. Gautam Khant. So all questions will be discussed among this, and I hand over the mic back to Srinivas sir.
Okay, I was actually holding on to the mic only, so. So questions access is there with Gautam Khant sir?
It's me with me, sir. I'll be pointing out. The question access are with me, sir. I'll point it out. So the first question is, first statement is by Pushpanjali Solanki. She, after Anirvan sir's talk, says, respectfully, the test batteries approach is best in vestibular assessment. We can disregard the test administration. This is more not a question, this is a statement, sir. Sorry. Choosing the test itself is key of trained professionals. Fallacy of test can negate to administer test clinical judgment. Okay. I'll come to the first question.
Yeah.
The first question is by one of the person who has been a guiding spirit for at least our group, this UVSB group, that is Dr. Satyabrata Fukan sir. His question, again directed to Anirban sir, is you have again, it's a congratulatory message saying that you have actually given a very nice talk on pros and cons of vestibulometry. Go again. Okay. Yes, the first question is from Dr. Devi Durga Das. The question is, can Unterberger's test be abnormal in central cause also? If it is abnormal, can it be confidently said that the cause of vertigo is of peripheral origin? So I leave it open to the panel. Who would like to take that question?
I think we have Dr. Vijay Guge is there. We have a neurologist among our panels. So
Yes.
because it is a question related to neurology, I think we will have the best person to answer that. Dr. Vijay. Dr. Vijay Guge?
I think he is not getting it.
Hello.
Yes.
Yeah.
So what is the question?
Sir, I will put the question again. Can
Yes, sir.
Underberger's test be abnormal in central cause also? If it is abnormal, can it be confidently said that the cause of the vertigo is of peripheral origin?
Sir, if there is ICA infarct, in such situation, you will get both peripheral as well as central sign. But you have to correlate it with clinically. If ICA territory infarct is there, then there is involvement of the vestibular nucleus. So we can get a finding of both central and peripheral. In such situation, Unterberger test can be positive in central cause also. Hello.
Yeah.
Yes, sir. Thank you, sir. Thank you. So it does not mean that it is specific to peripheral.
Yes, sir.
Okay,
we have to
okay,
correlate clinically with all other findings of central vertigo, central causes.
Thank you. There's another question. This is, I think, directed at Anirban Biswas, sir. Sir, the question is, if at all we do need to have only one vestibular investigative tool with us, what, sir, do you recommend we should have?
Okay. So, see, let me answer the first question before this. The previous question was not directed to me, but yet then let me answer that. Then we will go into this.
Yes,
see,
sir.
one thing we have to know is that the Underberger stepping test, though all of us do it, it is not a very reliable test. CCG and Underberger's test, both these tests, you will not find it being done by each and every well-known neurologist. They usually do not do it because also we find in our practice that when the tests are showing a left peripheral vestibular lesion, in the Underberger stepping test, we have found that there is no abnormality whatsoever, because if the compensation takes place, then you will not be able to find out what is there. So it is not a very reliable test. And moreover, that wide sway that happens, as it is said, that there will be a wide sway during the Underberger stepping test. When you are stepping, if it's a central lesion, there will be a wide sway. That also is not a very good marker, and just on the basis of that, you cannot label it as a central lesion, because in acute peripheral lesions also, the patient's sway will be wide. So in most of these well-known neurological centers, they do not commonly do the Underberger stepping test. And even in that Michael Stoops 5 tests and 6 tests, and not a question of Michael Stoops test, these are all well-known universal things. The Underberger stepping test is not a very accepted and a reliable clinical test, and its counterpart of investigation, that is the CCG, is also accordingly not a very reliable test. It can just raise an index of suspicion, but do not ever decide your diagnosis on the basis of the Underberger test only. This goes about my feeling on the Underberger stepping test. It's a personal feeling. Secondly, is answering this question about what instrument to have if you have one instrument. Well, if you have one instrument, and also if you have a deep pocket, then the one instrument I would say is the video head impulse test with the oculomotor tests incorporated into it. Because one company, see, this is not a commercial platform, and I will not promote anything or show anything which belongs to one company, because we are against that. And I am personally against all this nonsense that takes place in the name of academics, all sponsored by pharmaceutical companies. I usually, Gautam knows it very well, that I do not actually participate in this pharmaceutical company or instrument company sponsored, sole sponsored meetings. But the point is that we had long discussions with it. But let me also tell you that, yes, there is a company that makes these VHIT machines in which you can do the caloric test as well as all the oculomotor tests very well. It is pretty costly, but if you can negotiate the price, you can get it at a reasonable cost also. And it is in one company's VHIT machine which comes with software for the caloric test as well as for all the oculomotor tests that you do, and other tests you do clinically. And if you don't have the money to buy a complete VHIT system, at least buy a good quality Frenzel's glass. That I think is the only thing that you require. And if you have a very good quality Frenzel's glass, that should be good enough to record everything. And the next thing, if you can get a little more money, that same Frenzel's glass, if you are nasty enough to fight it out with the companies that sell these products, these VNG machines, then in the same Frenzel's glass, the software of the VNG can be incorporated at a little extra cost. So the question is that all of you, most of you are not whole-time neurotologists like me. So it is not expected that you will be having all neurological equipment only. For you who is a practicing ENT doctor, it is much more worthwhile if you buy a laser, if you buy a high quality microscope, because we are talking to a lot of ENTs or other people. But that does not mean that you will not do ENT and you'll put your life into neurology only. That is not what is expected. So your money should go more into buying surgical equipment and high quality surgical equipment, because that is what you basically are. And that is what you are basically trained for. But so one good thing that you can have is, first, learn the clinical test history taking properly. It has been very well covered in today's meeting. You learn these two processes and buy a good quality Frenzel's glass. Get a little more money, negotiate with these companies, and they will be able to give you the software for a VNG at a little extra cost. And in the initial stage, if you can get some amount of money, then buy one instrument is the VHIT. The advantage of the VHIT machine is that you a very little footprint. So since it has got a very little footprint, it comes in a small portable box, slightly bigger than a mobile phone. So you can carry it in 5 clinics where you're going. You can carry it to a patient's home also if you are wanting to do it over there. So that would be a good investment. I believe I've been able to make myself clear without giving a partition view.
Yes, sir. Thank you very much, sir. Now, the next question is again from Dr. Satyabrata Fukan. Is Gendrasic's maneuver in Romberg's test helpful? So, to Pratik.
Dr. Surajit.
Yes.
I think Pratik is facing some issues with microphone right now.
Okay, so will you take that, Dr. Srinivas?
Sir, this is a specific question for Dr. Guge.
Yes, sir.
Okay, Dr. Guge, please, sir.
Gendrasic's maneuver basically designed for the reflexes, because after doing Gendrasic's maneuver, if you are not able to elicit the reflexes, you are able to elicit some form of reflexes, deep tendon reflexes. To increase the sensitivity of Romberg's test, there are few different methods. Initially, when the Romberg's was designed, at that time, they have make it a wide base or normal base, normal stance. Normal stance is less than 12 inches. If it is more than 12 inches, then it become a wide stance. So what they have made, the first modification was made in Romberg's, that is to decrease the stance. That means bring both the feet together. That will increase the sensitivity. Then eyes closed with arm, outstretching of the arm. That is one of the another modification which will increase the Romberg sensitivity. And third important thing, what they have done, to move the neck of the patient here and there, so that he will get distracted. like Dr. Pratik told, in Romberg's test, by writing some numbers on the arm. These are the maneuvers basically used to increase the sensitivity of the Romberg's test. Gendra 6 maneuvers basically is not described in the literature. They are predominantly described in terms of deep tendon reflexes. Hello.
Thank you very much, sir.
Yeah.
The next question is from Dr. Fauzia Shirin Hakim from Dibrugarh. And this is directed again at Biswas, sir. Sir, the question is, I want to know from you which test of vestibulometry helps in diagnosing cervicogenic dizziness?
No test. No test in vestibulometry is capable of diagnosing cervicogenic vertigo. There is one test which I had done and tried to promote here and there, is that it's a clinical test. You make the patient sit on a revolving stool which does not have any handle. You just make the patient sit on a revolving stool. Somebody holds the patient's head tight from behind, and then you rotate the stool. So when you are rotating the stool right and left as much as possible, and somebody from the back is holding the patient's head, then you are stretching the deep cervical muscles. And if that makes the patient get a feeling of head ataxia. Remember the word head ataxia. You don't expect much of nystagmus to be seen, or you don't expect that the patient will be getting a spinning sensation. The term head ataxia means that my head is not stable on the shoulders. So if the patient gets a feeling like that, when you are doing a thing like that, that means the patient sits on a revolving stool without handles. Somebody holds the head from behind, and you turn the patient's torso as much as possible to the right and left, because that then stretches the deep cervical muscles. So this is a study which I had done, and I had presented many years back in the International Neurological Society, and it was appreciated over there. But we are extremely lazy to make a paper out of it and print it and then do anything about it, but then never try to follow it up. But that is something which we do in our patients off and on in clinical practice. And if the patient says that, yes, I am feeling the same feeling, then we think that it is a case of cervicogenic vertigo. And if it is a case of a patient of cervicogenic vertigo, what treatment? We basically send the patient to a physiotherapist and give some muscle relaxants. Okay.
Thank you, sir. So the next question, Srinivas sir, whom should I give? Any role of going for ECG and halters in a case of dizzy with a syncopal type of attack?
Sir, this is
Gautam, can I answer this? See,
yes,
the thing is, we do get in our clinic quite a lot of patients who come with these types of syncopal attacks. We get lots of patients like that. In fact, see, what happens is, in different levels of practice, you start getting different types of patients. Like, we do not get as much of positional vertigo patients as one would expect. We get much more of say patients of these pre-syncope and syncope. We get much more patients of psychogenic vertigo, PVPD, etc. So it depends. In our types of practice, we get more of those types of patients. These patients, what we do is that, rather than doing the ECG and these things first, in ECG you're not expected to get anything much. The test that we do and advise the patient is that number one is test for orthostatic hypotension. That means patient lies down in bed for about 20 minutes. Then somebody measures the blood pressure, records it. Patient suddenly stands up, pressure is measured and it is recorded. Then again, patient keeps on standing. 3 minutes later and 6 minutes later, the blood pressure is again taken and it is recorded. If the systolic falls by more than 20 millimeters, or if the diastolic falls by more than 10 millimeters of mercury, then we call it is a possibly a orthostatic hypotension. In these patients, we also advise two investigations. One is we ask for a tilt table test with GTN provocation. It is done in high class cardiological centers. And another test that we do is ECG with carotid massage. Patient lies down, and this also is done in a place where you can have good cardiological backup, because sometimes the patients get a severe syncopal attack. Patients can also get a sudden cardiac arrest or something, but then the patient revives immediately. Nothing actually happens. But then an ECG with carotid massage and a tilt table test. It is also called a head up tilt table test with GTN provocation. That is done, and we ask the patient to do the test for orthostatic hypotension not once. I'll tell the patient that you do it once tomorrow at evening, 2-3 days later you do it in the afternoon, again a few days later you do it in the morning. At different times you see whether, because most of these patients are taking blood pressure pills and sometimes they get orthostatic hypotension. So I believe this should suffice rather than doing an ECG. If another test which you can do is an echocardiography, that may sometimes help. You can do a treadmill test also, but then basic tests are tests for orthostatic hypotension, head up tiltable test with GTN provocation, and ECG with carotid massage.
Thank you, sir. The next question is from Mr. Dr. Dungarwal. His question is how to diagnose migraine vertigo.
I think Dr. Bijlani can answer that question very eminently.
Well, it's purely by history. I think you will agree, Dr. Srinivas.
Yes, sir. So it
Am I audible?
Yeah,
yes.
you are audible.
It's
basically
purely by history. See, by the rule, or rather based on the criteria laid down by the International Society, the patient should have had a history of headaches, and that could have been rather in the past than in the present situation, because it's a very well-known fact that most of these patients who present with vestibular migraine are in the late 40s or so. So you have to ask for a history of headaches in the younger age, and then you have to ask for the history of aura. Then you have to, aura means whether the patient has any visual aura or something beforehand. Besides that, Dr. Srinivas very aptly said during the clinical history part that you have to ask for triggers. Does it occur in times of stress? Is it happening when the patient has had a lack of sleep? Or is it happening when the patient has missed a meal? Or is it happening if the patient has had overeaten? And also there are certain food items like cheese and red wine, etc. There's a long list, in fact, available. So it's purely based on history rather than any investigation. Maybe Dr. Srinivas does want to add something, or Anirban.
That is perfectly summarized. Perfectly summarized. Thank you, sir.
Thank you.
Yes, sir. So, Dr. Surajit, any further questions?
Yes, sir. There's lots. The next question is again from Dr. Satyabrata Fukan. Mechanism of C-VEMP in superior semicircular canal dehiscence syndrome. It's a question. What is the mechanism of C-VEMP in superior semicircular canal dehiscence syndrome? Can it detect all other third window syndromes?
Yeah, so I think I'll take that question, and it is very sensitive for third window, because what happens is the inner ear in the presence of a third window becomes super sensitive, okay, to anything, including the air conducted sounds. So that is the reason why the same amount of energy, okay, which you expect at in a normal person at 90 decibels or 100 decibels, that amount of energy is received by the inner ear structures at 70 or 60. So because of that, you get a very low threshold in third labyrinthine windows. Yeah.
Thank you, sir. The next question is again directed at Srinivas, sir. The question is, what is the difference in positional and positioning tests?
The difference between positional, see, tests are the same. The finding is what is different. So in positional versus positioning, positioning means the act of changing the posture has brought about the symptoms. The act of changing the posture has brought about the symptom. Positional is that particular posture is bringing about the symptoms. So generally the act of changing the posture means previously you are upright, the debris was in one particular place, you changed to another position, the debris moved. Therefore you get vertigo. That is positioning. That is generally associated with benign paroxysmal positional vertigo, especially the canalolithiasis or what we call as a ductolithiasis variety. Whereas positional means as long as you maintain that position, you get vertigo or you get nystagmus. So that is positional, not positioning. There is no change. So in that case, it is more likely one possibility is that it can simply be case of cupulolithiasis, but the other possibility is that it is a central cause, okay, where the otolithic inputs are being misinterpreted. So otolithic tilt inputs are being misinterpreted as otolithic continuing translation inputs. So that is again considered as a central dysfunction. It can happen in nodulus and ventral uvula dysfunction in the cerebellum. So that is one possibility.
Thank you, sir. Now this question again is directed at Biswas sir. The question is, false results are most commonly encountered with which investigation?
Okay, false results are mostly encountered with which investigations? All.
Yes, sir. Yes, sir.
Answer is a big all with a capital A, capital L, and another capital L. In all of them, you will be getting false, but mostly false things are there in the VNG recording. That is what I think. But then anyway, or in all of them, you will be getting a lot of these wrong recordings and improper test results. So never go into the report first. If you have not done the test yourself, see the recording and learn how to interpret a recording. And not only interpret the recording, from the recording, it may appear to you that, okay, this patient is having a, say, hypometria in the VNG graph that has been there. It is possibly a hypometria. Now, when you have found that, again check it clinically. Now you know that it is hypometria. Okay, that has come in the VNG finding. So then you check the hypometria again clinically. See it. If you have a video frenzel, then do the test clinically and record the video recording. Analyze the recording slowly. That means analyze the recording in slow motion and see if it is a true hypometria or not. If your clinical findings do not match with the investigative findings, your clinical findings remains the winner. Get this clear, that if the clinical findings and the investigative findings do not match, believe the clinical findings, not the investigative findings. Clear about this?
Yes, sir.
Thank you very much.
Okay. The next question is from Dr. Isha Preet Tuli. This question is directed at Dr. Srinivas. In your opinion, what type of patient profile is seen in triple PD? Do you perform any psychological test on them?
See, especially the triple PD is very common. It used to be thought that it is common in women. No, the most of my triple PD patients are men, young men. Okay, that is very, very common. Among young men, I don't know for what reason, triple PD is very, very common. So, most of the time, I take the help of the psychiatrist to treat them. Okay, so because for some reason, they are never satisfied, they are not very happy. So, it is always better to seek help.
Okay, sir. Thank you, sir. Now, the next question is from Dr. Sambhunath Mukherjee. Again, he is an eminent ENT specialist from Guwahati. What is the present status of CVAM? How reliable is it in the present scenario?
I think Dr. Charuhas can take that question. Charuhas, sir. Is Dr. Kshitij is there in the panel?
No, sir.
Okay, okay. So CWEMP, in the sense, see what is happening when it comes to WEMP is, of course, there are a lot of papers both this way and that way, but WEMP is gaining prominence. WEMP is gaining a lot of prominence of late. So CWEMP and OWEMP, both of them. Okay, so CWEMP for saccular dysfunction, but we should always remember that saccule has a dual innervation. Saccule has an innervation from inferior and superior vestibular nerve. So partly from there and partly from here. So though especially in case of superior vestibular neuritis, we expect that the CWEMP to be completely normal. We do see some amount of reduction in the threshold even in that. So that way that we have to keep that in mind. And of course, for the diagnosis of third labyrinthine windows, WEMP is a very, very beautiful tool. And one more thing is to differentiate between migraine and Meniere's disease. WEMP is gaining prominence for the shift of the frequency tuning. What I mean by shift of the frequency tuning is general best WEMP threshold come at around 500 hertz. But in case of people with Meniere's disease, that instead of getting the best threshold at 500 hertz, it shifts to say 1000 hertz or 2000 hertz, something like that. So for that role also, WEMP plays a very good role. So for that matter, it looks like WEMPs are here to stay and grow.
Sorry, but can I also add a
little
bit?
Yes, sir. I know you have a very, very passionate opinion about WEMP. I have heard of that. So we want to listen to that.
See, the point is, Shambhuda, first, my regards to you. Shambhuda has been one of the earliest patrons of neurotology, and I am extremely grateful to him for a long association that we have together. Shambhuda, see, to know the role of WEMPs, there are two things that I would want you to read. If you do not have access to it, it is easy to get. Please read the paper published by in the Journal of Neurology, December 2017, on the basis of a study by some stalwarts on practice guidelines on WEMP. There, the WEMP test was analyzed on 4 counts. Number 1 is, does it help in the diagnosis of semicircular canal dehiscence? Number 2 is, does WEMP test reliably identify disorders in the saccule and utricle? Number 3 is how much is the WEMP test suitable for diagnosing BPPV, and how much is the WEMP test suitable for diagnosing of Meniere's disease? Now the questions, these 4 questions had to be answered by that group, and the findings of that group was that it is effective in diagnosing of semicircular canal dehiscence and third window syndrome, number 1. Number 2 is that utricle and saccule disorders cannot be diagnosed. It is level U evidence. Level U evidence means there is no solid evidence or no dependable evidence that the CWEMP can diagnose utricular saccular disorder and OWEMP can diagnose utricular disorder. So there is no solid evidence for it. They have not rubbished it, but then they said that evidence is not adequate to suggest so. Number 3 is that whether it can diagnose BPPV, answer is no. And whether it can diagnose Meniere's disease, the answer is no. Please read up that article. We are nobody to pass our comments on this, just on our own personal experience. And I do not know how many WEMPs all of us do, and also correlate it with the patient's findings. If you are not doing adequate amount of WEMPs and correlating it with the patient's findings and other clinical findings, just on hearsay, it is not proper to say, ye hum kar deta hai, wo hum kar deta hai. Let us go by what clinical research says, and this is what clinical research says about WEMP. Number 2 is another place where you can know and learn about WEMPs is go to the Timothy Hines website, Vertigo and Dizziness, vertigoanddizziness.com or something is the name of that site. Just type out Timothy Hine and you'll be able to find out.
Dizzinessandbalance.com. Dizzinessandbalance.com.
Dizzinessandbalance.com. There, find out about VEMS in miniature disease and VEMS in these things. You will know. Say, I don't have the time to go into the details because I myself have a presentation on VEMS in miniature disease. See, partly my experience and partly by reading up what these big people and the stalwarts have said about this. So it is basically on that. So the point is that VEMS are, I believe, overhyped now. So though it is a test and all, but just on the basis of a VEM, do not make a diagnosis that it is Meniere's disease or it is BPPV or that the utricle is bad or the saccule is bad. At this point of time, I don't think we are in a place like this. I know what I am saying. I am studying a hornet's nest, but at the same time, this is what literature says. If you can go through literature and find out something better, read it up and form your own opinion. Do not go by what I am saying. Is that conveyed properly?
Thank you, sir. The next question is, how do you diagnose benign paroxysmal vertigo of childhood? This is from this question comes from the person who actually established neurotology in the Northeast, I have to say, Dr. Akhil Sharma, sir. After Goswami, sir, he is the person who actually has done a lot for neurotology in Northeast. Akhil Sharma, sir, his question is, how do you diagnose benign paroxysmal vertigo of childhood?
So benign paroxysmal vertigo of childhood is, the presentation is very, very typical. Okay. So the child tells that, okay, I have some videos also. In fact, one of the presentation I had shown one video where the child at that particular point of time when they cling on to the mother. They cling on to the mother. It lasts for very momentary. It is like less than a minute or max 1.5 minute max. Then after that, the child becomes playful again. But during that time, it is very scary for both the child and the parents also. So this kind of episodes keep happening recurrently. And when you take the history, there may be a family history of migraine. So this is how, based on the clinical presentation. In fact, sir will agree with me that the best way to diagnose is to entertain the diagnosis. First and foremost, in our availability heuristic, that one of that diagnosis should be there in our mind. If it is there, then we will immediately pick it up based on the history. When the mother or parents are telling the history only, we know that, oh, we are talking about a benign paroxysmal vertigo of childhood, for the reason that it is short-lasting attacks where the child clings on, tells everything is going on, and there is one full list. In fact, I can share that presentation with you where all the different types of words that children with this condition have different kinds of descriptions that they are given is all there in one slide. I will share that with you, Dr. Surajit. Maybe you can share with all the delegates once.
Sure, sir. Sure, sir. The next question is directed at Biswas, sir. So the question is, what is the reliability of glycerol test for Meniere's disease?
Difficult questions to me. Something very difficult to answer. See, the thing is, in all patients of suspected Meniere's disease, both as well as the ECOG. The tests to confirm glycerol disease, the tests to confirm Meniere's disease are: number 1 is glycerol test, number 2 is ECOG, and number 3 is the intratympanic gadolinium injection radiology. So these are the 3 things that are there. It is said that just with the glycerol test, you are more or less 1/3 sure that it is there. If the ECOG is also positive, you can be more or less 75% sure. But the gold standard is doing the intratympanic gadolinium enhanced imaging study, in which, since the perilymph takes up the gadolinium and the endolymph does not take up the gadolinium, in a patient of Meniere's disease, you'll find a black area surrounded by a thin white area, which is the perilymph. So which means that the endolymph has the volume of the endolymph has increased. So by that is the best way of doing the test. You read up papers from Dr. Gyurkov. He has got a lot of publications on this to say on these different tests for this thing. But if you don't have an ECOG, and since getting the intratympanic gadolinium contrast MRI done is also not very easy, you do the glycerol test, and that is a good poor man's way of confirming Meniere's disease. Let's put it at that.
Thank you, sir. The next question is again from Mukherjee, sir, Sombanath Mukherjee. Importance of triphasic nystagmus on hyperventilation.
Dr. Surajit?
Yes, sir.
Okay. See, triphasic nystagmus, few cases of triphasic nystagmus we have seen in practice is in recovering vestibular neuritis. Okay.
Yes.
So maybe it is possible that a similar pattern is seen in cross compressions or a similar pattern is seen in demyelinations, but I have not come across them. Okay. If Dr. Mukherjee has actually seen, maybe it is better that he shares his experience also.
Okay, sir.
Because these are few cases, and then it is better that we have a larger experience from different people sharing, so that we have the entire spectrum of those things. But the few triphasics that I have seen till now belong to vestibular neuritis. Okay. And acoustic neuroma also may be possible, but I have not come across till now.
Okay.
Or vestibular schwannoma, more specific to be the purist.
So the next question is directed at
Dr. Surajit?
Yes.
Dr. Surajit?
Yes, sir.
What's your opinion about triphasic nystagmus?
Sir, I haven't seen it. So as you said, sir, I have very little opinion on that, sir. What I know is what you have just said, sir.
Yes.
This is a question from Dr. Santosh Kulkarni. Why is nystagmus vertigo sometimes not seen in a clinically sure case of BPPV, and it becomes evident after repeated testing, maybe days apart? This question is directed both to Biswas sir and Dr. Srinivas.
Sir, Rohiwal sir will give the best answer for this.
Rohiwal sir? Yes.
Can you repeat the question?
Yes, sir. This is from Dr. Santosh Kulkarni. Why is nystagmus or vertigo sometimes not seen in a clinically sure case of BPPV, and it becomes evident after repeated testing, maybe days apart?
There is a likely possibility of more dispersion of autolytic particles, and then there is a stimulation and you get nystagmus after few days. It may not be, possible when you are demonstrating in initially. It is evident in a later stage.
Okay, sir. Thank you, sir. Question by again Dr. Ishaprit Tuli. This is directed at Dr. Pratik Parwal. Is timed up and go test should we do in an elderly patient? Many of them use a walking stick. Also, what type of anomalies do you look for when you observe the patient getting up from the chair?
I'm not sure whether Dr. Pratik's microphone has got corrected.
Okay, because he has unmuted.
Timed up and go test, the way it has been designed was not for people with a problem who are using a walking stick or anything. So it was more meant for
active
people who are not doing that, who just get up, who are not using the stick, that kind of thing. So can you just repeat the question again so that I can?
In timed up and go test, should we do in an elderly patient? Many of them use a walking stick. That is the question.
Should we do? Yeah, should we do in an elderly patient? Yes, it is a test for the elderly people only. Okay. In fact, most of the people who qualify for that test is the elderly. And I do understand that most of them use the walking stick. To frankly, how to interpret with and without a walking stick, As of now, I am blank. Maybe we can do some reading and try to answer. Maybe in the next 2-3 days.
Yes, sir. So the next question is from Dr. Shah from Patna. What effect of hyperventilation causes changes in the nystagmus? And his added question is, what reference is there for the relevance of VEM in menias? So the first question, effect of hyperventilation causes in nystagmus.
When it comes to hyperventilation, there are 3 things that can happen to nystagmus. A previously non-existing nystagmus can appear on hyperventilation. The other thing is, previously existing nystagmus may increase in intensity. That is the next finding. Then the third thing that can happen on hyperventilation is the previously existing nystagmus can either suppress or even change direction on hyperventilation. So there are the 3 different kinds of findings in hyperventilation on nystagmus, the effect that hyperventilation has on nystagmus.
Thank you, sir. This question is from Anil Krishna. The question is, he identifies himself that, sir, I am basically an audiologist. He is very much interested in vestibular testing. So he says, can you explain what would be the maximum role of an audiologist in the whole subject? And can we do all the tests which are explained here so far? This is directed at Srinivas, sir.
Tests, definitely they can do. Tests, definitely they can do. Okay. In fact, all the tests, it is, see, a lot of people keep asking me, whom should I go to? I have a headache. Whom should I go to? Should I go to a physician? Should I go to a neurologist? Should I go to an ENT? That is the common question that keeps coming. Okay. So same thing. I have a vertigo. Where should I go first? I will tell them, every ENT or every neurology may not be interested in vertigo. But the moment you go to the particular person, within 5 minutes, you will know whether that person is actually interested in treating you or not. If you get the feel that that person is interested in treating you, you go to that person. Okay, I don't go by specialty, whether you are a neurologist, whether you are an ENT, no. Whether that particular person is taking interest in that subject. Okay, somebody may be only interested in a particular branch. Okay, so for example, I may be only interested in treating a particular group of disorders in ENT. So in that case, I may not have an interest in vertigo or in the headache part. So in which case, within 5 minutes, the patient, it is easily conveyed to the patient that, okay, patient understands that this person is not interested in this. Same thing, when it comes to neurology, somebody may be specializing in movement disorder. Somebody may be specializing in, have a special interest in epileptologist, something like that. And there is somebody else who wants to help the person with vertigo. So within 5 minutes, you know that. So this is what it should. It is about whether the doctor, don't go by the qualification, go by whether the doctor seems to be interested in treating your condition, number 1. When it comes to audiology, what all the audiologists can? Definitely any investigation that is there in the vestibular test battery, after proper training, just because, see what happens, I have a qualification with this BSc Audiology, MS, BSc Audiology and Speech Language Pathology, maybe there, but then you should have trained. You should have trained in a correct place in the correct technique. Once you have been trained in the correct place and correct technique, your qualification does not stop you from doing all the tests. You can go ahead and do all the tests.
So what you are basically saying is it's not your degree, but your knowledge that matters.
Degree plus knowledge. So audiology degree is enough to do the vestibular test battery. Okay, so you should have trained where you are doing the correct interpretation of the tests correctly. So if you are doing the correct interpretation of test and you know the correct technique of test, then you can do it. Who stops you from doing the test? In fact, lot of ENT surgeons across the country are actually looking to employ audiologists who can do the vestibular test battery. We are not having enough audiologists who can do it. That is why there are so many people who are actually they're looking for audiologists who are well trained and who are looking to do the test to employ them.
Thank you, sir. The next question is again from Dr. Sambhunath Mukherjee, sir. What is light cupola syndrome? Is it related to press by vertigo?
Dr. Surajit, that question is for you.
I know you have
written a paper. You have written a big paper on light cupola. So now from yourself.
So basically, what is light cupola syndrome is basically what happens is in cupular lithiasis, the basic theory is that the otolith attaches to the cupola becomes heavy, and that causes the malformation leading to dizziness. However, these are mostly Korean studies which have found that in some people, these are studies by Kim et al., Imai et al., and all that, where instead of the cupola falling down, it actually floats up. There are a number of theories being put up for that, which includes the endolymphatic fluid becoming lighter because of something, heavier because of external things like, or sometimes the attached otolith may become lighter and it may cause something like a ballooning effect. So is it related to presby vertigo? It can happen at a certain age, but it is not definitely only because of that, because it can, again, as I mentioned, happen at any age. So for now, anything else you'd like to add, sir? Then I'll go to the next question.
Sir, nothing more to add.
Thank you, sir. So then we have a question from its name is Kram Babu. Does vascular loop around the eighth nerve cause vertigo and tinnitus? I think that will be a big yes in some cases, but not in all cases. Am I right, Dr. Srinivas?
Yeah, I think we can ask Dr. Anjana's opinion on this.
Yes, Anjana ma'am, if you can give your opinion.
Yeah, it can cause, but not in all the cases. But I have never encountered this condition.
And
It can
Dr.
cause.
Vijayan has one of the biggest series of cross compressions, and he was the first person to actually make a poster about cross compression in Moscow. Okay, that was many years ago. At that time, I had not even heard of cross compression. At that time, he had made a poster. Not many of us has actually heard of cross compression. So I think we can take his opinions.
Oh, well, thank you, Dr. Srinivas, for all the compliments you gave me. In fact, the poster in Moscow was triggered by the very first patient I diagnosed as vestibular paroxysmia, and that lady around 40 years of age responded very well to carbamazepine, and that was you can say a high point for me to start believing in the occurrence of vestibular paroxysmia. Okay. So, you see, in fact, the idea is about the loop bothering the vestibulocochlear nerve, not alone the vestibular component. So it depends on how much, which component, whether the vestibular component or the cochlear component is being affected by the loop, the compression that the loop is causing. And that will result in the symptomatology of the patient. I have definitely seen a patient, not one, but more than one patient, in whom tinnitus is definitely a component of the symptomatology. In fact, there's a paper which describes only a typical type of tinnitus, and I don't remember exactly the origin of that paper, but it says typewriter tinnitus being caused by the vascular loop. So yes, definitely, both the things can happen, and also fluctuating or a permanent hearing loss to a certain degree can be seen in patients of cross compression.
Thank you very much, sir.
Thank you.
So we will be taking the last question now. This is from a very good friend of mine, Dr. Kritamoy Nath from Silchar. He's a faculty in Silchar Medical College. How common is the vertigo in children and its types? The second question is, what is a bucket test? And the third question is how to do positional test in restricted cervical movement. So the first question, how common is vertigo in children and what are the types? Sir, Anirban sir, you are muted.
Answer this. If he answers it, anybody else answers it, then it's fine.
No,
Otherwise,
sir. Please, sir.
okay. First question is, how common is vertigo in children?
Yes,
That is
sir.
the question number one. Not very common, because I believe children enjoy the vertigo and do not complain until it is a severe case where they cling to their mothers. And as Srinivas explained, that's the typical cases of benign paroxysmal vertigo of childhood, where these things sometimes happen. Otherwise, children reporting with vertigo is not very common. And what common literature, what the current literature says is that children reporting with vertigo, initially we used to know that most of it is benign paroxysmal vertigo of childhood. But now it is being said that that is just about 35 to 36%, not more than that. A much greater percentage is of these children reporting vertigo is psychogenic in origin. So you see, the psychic part is becoming more and more relevant now. That was the first question. The second question was what? The second question was?
So the second question was, what is the bucket test?
Achha, bucket test, bucket test is basically a test of subjective visual vertical, and it evaluates whether your perception of verticality is coinciding with the gravitational vertical or not. In a normal person, what I presume to be vertical must coincide with the gravitational vertical, and maintaining that is the function of the vestibular labyrinth. Now, which part of the vestibular labyrinth is not known very well. Some people say it is the otoliths, some people say it is the utricle, and some people say that the semicircular canals as well as the cerebral cortex also, everything together contributes to our sense of, to our perception of verticality. So the bucket test basically tests our perception of verticality. It is not a very specific test of topographic diagnosis. It does not tell us which is actually at problem. But if you go by common means folklore, let's put it that way, then the utricle can be linked to it. That is about this test. A much refined way of doing the vestibular of this subjective visual vertical test is using the computerized subjective visual vertical. But as we said, we want more of this clinical test, and so the subjective visual vertical test done by the bucket system is a good enough test. So if you do it, it is good, and it is a useful test in clinical practice. And the third question was what?
So the third question is how to do positional test in restricted cervical movement.
Oh, achha, that we get quite a bit of patients who will not even allow us to do the maneuvering or do the Dick-Solpeig test, because some God-forsaken person had asked for a cervical spondylosis cervical spine X-ray, and it has been diagnosed as a cervical spine disorder. And so they think that, and the doctor has told them that you should not move your spine, cervical spine very much. And when you say it to them or try to do it, they will resist. So in our clinic, we have got a proper chair for this, which we have devised ourselves. It is the same as what is marketed by a company in the name of TRV chair. We have made our own chair. There are other practitioners in India also who have made a similar chair by themselves, and we put the patient on the chair where the patient can be rotated as a whole, and then the traction on the cervical spine is not there. The entire body of the patient is rotated this side, that side. After in the chair, the patient is anchored by tapes and all, and then this chair can be moved in all the different angles, and by that we do it. So for us, that is not a problem. But of course, the patient pays nearly 4 times the price of what we charge normally, because we don't charge extra for the maneuvers, just the consultation fee. But if you do it in the chair, we charge 4 times the amount. So that we'll have to do it over there, so we'll have to pay more. So that is how this thing was. But then it can be done extremely efficiently without in any way tilting the cervical spine at all. The entire body is tilted. Okay. So I believe this was the last question, and I found from
sir,
the
1 minute, sir.
chat box it
Sir,
is
1
given
minute.
about
Sir,
10 big thank you.
Hello, sir. 1 minute, sir.
Yeah.
Hello.
Yes.
Sir. Dr. Dharma from Nepal has sent one answer to one of the previous questions. Time up and go test to check the risk of fall on elderly patient. This is what he has sent a text message to me. I'm reading that. They have to complete the 3-meter walk in about, in a few seconds, that is 5 seconds. If they exceed more than that, they may have high chances of fall. So what he is telling for stick, if the person is having a stick, you have to do the test without the stick, and the timing starts as soon as the clinician says go, and the time stops when the patient comes back and sits on the chair. So this is what he has written. Hope that will help. Okay, in answering the previous question about the stick. And one more thing about falls and syncope. I think we should take Dr. Charuhas's opinion because he has a different level of expertise when it comes to falls. Okay, especially managing Tumarkin's crisis. He has a lot of patients is managed. So if he's last time we could not get his mic, if it is working, maybe he can give his opinion.
Sir, Jagtap sir.
I think there is some issue with his mic. Okay.
Yes, sir.
Okay, sir. Then
so,
sir, thank you very much.
There's one last question. The question is, are all these presentations available on the net? The answer is from the organizers. I'll tell it. Yes, it will be available in the YouTube. It's already going live and it will be available there. Plus, it will also be made available in our LiveMed website. We'll put in everything, all 3 days of it. So before finishing, I'll hand over to our convener, Dr. Gautam Khan, to have his final words.
No, thank you, everyone. It was a very lively discussion, and I think the viewers must have definitely benefited. We are looking forward for the next 2 days, of course. Thank you, Anirban sir, for sparing your time. And
Sir,
Srinivas.
1 minute. Sir, 1 minute. Gautam Khan sir is like Sri Krishna. He's always in the back, but he is sending Arjuna front. Gautam Khan sir is Sri Krishna, and Surajit Bhai is our Arjuna.
Arjuna will come in your sleep and dream if you compare me with him, boss.
We have a much more packed sort of day. Today we had a 4.5 hours of discussion on Vertigo. So I think we had a good audience, and especially from the audience, I shouldn't be singling out, but still then I'd like to thank Dr. S.B. Phukan and Dr. S.N. Mukherjee, quite senior members from the Northeast who have always been supportive of our...
And Akhil Sharma sir.
And Ishi Sharma sir as well.
And Gautam, another thing, another take from this meeting was that, I was having mental depressions, that it is only me who is not getting patients in practice now. My practice has come down to 20%, but that people could sit for 4 hours sitting through the webinar means not only my practice has come down, everybody else's practice has also come down. A busy practitioner would not have been able to spend 4 hours learning things now.
Yes.
So that gave me some amount of impetus that I am not the only one whose practice has come down in COVID times.
Thank you very much, sir, and good night to everybody. We hope to see you all tomorrow. Sir, if you are free, please do log in for the next 2 days as well. We'll send you the Zoom details for the next 2 days.
Yes. Okay. Thank you.
And to all the audience, you need to register for tomorrow's event again. So I hope you will register again, because each day's registration is separate. And at the end of the 3 days, anyone who wants an e-certificate can apply. And depending on how long you have been present in the webinar, we'll be giving e-certificates. Thank you all. Good night and see you all tomorrow.
Bye.